a competition, and then a number of speakers, Dr. Stone,
Because what they found here is, you go to the bottom, this is both vascular dementia and Alzheimer's. You can see this is actually hypertension, and this is actually elevated blood pressure, and this is normal blood pressure. Pointing out at long follow-up the question of hypertension dealing to the issue of dementia. I'd like to summarize, and this is two papers that we actually participated on them that have been published. Of all cases of cognitive impairment and dementia, cardiovascular risk factors contribute to 20%. In other words, all the cases of vascular dementia are related to risk factors, and in part to the majority of cases, even with Alzheimer's. And if I go back, for example, at what I presented here, it's interesting that the uptake of glucose is decreased in the same regions that Alzheimer's disease develops. Alzheimer's is a complex disease, but it's interesting because vascular disease maybe it potentiates the progression of such a problem. Well, all of these led us to develop a real prospective study with the imaging technologies that I mentioned and more. This is a study of 1 million individuals. It started in 2022 and is going up to 2030, which is 1,000 participants, as I mentioned. 60% are men, 40% are women. And here we look at 3 different methods of cognitive dysfunction. And here are all the biomarkers that today we talk about dementia and so forth. The study is going on, and certainly is very fascinating. And what is interesting is when we ask people to enter into a study of the brain and cognitive function, they come very quickly, very easily to enter individuals today when you study something related to the brain. Well, I didn't finish because one of the most interesting aspects that I want to present today is what we found in a mouse model of Alzheimer's disease. This model is in Madrid, is well known. And basically, this is actually autopsy of animals that develop Alzheimer's. And I don't go into the details. This is published in 2024. Here, what we found is beta amyloid is prothrombotic in the small vasculature. And if you give dabigatran, reaching a dose in blood very similar than what dabigatran when we give in patients with atrial fibrillation, the equivalent, we see a significant decrease in the progression of Alzheimer's or even stop it, pointing out that perhaps occlusion of the small vasculature by blood clots may play a role on this condition. But then the study progress in vivo, and the progression in vivo is fascinating. What we have is positron emission tomography in the mouse model that can identify fibrin. And this is actually the Alzheimer's. You see this in dark? This is the detection of fibrin, and this is actually the controls, which led us to go to humans. And you say humans? Yes, then is autopsy. In Spain, in Barcelona, there is probably one of the largest groups of Alzheimer's disease that is actually in a trial basis, and we are part of them. So what we did is we look at the brain of people who died of Alzheimer's disease and by immunofluorescence to look at platelet deposition and fibrin burden, which you can see here. And as you can see, there is a relationship between both, between fibrin deposition and platelet. So there is no question when Alzheimer's says this is an atherosclerotic process. I wonder if what we're looking at is actually these clots that may be organized in these brains. Well, the question, and I am going to finish, the question here is what do you do about it? Our feeling, and again, I am a cardiologist and a complete amateur in neurology, except I'm very involved with these studies, is what can you do to prevent dementia? Well, for what we know thus far, Alzheimer's is complex, but we believe that even the risk factors may make the progression of the disease, which is a vascular component, cholesterol, diabetes, and actually hypertension. So the first thing to do is to treat these. But do you accomplish something when you treat somebody at age 65 or 70 rather than at age 30 or 40, which is when this whole thing probably starts? But there's something else, and that is now very interesting data that behavior change can stop the progression of the disease or decrease the progression of the disease. What that means is being socialized, not be isolated, exercise, and being motivated. And the data in the literature is coming one paper after the other. These papers here, what they try to say is that if you change behavior, you may have results very quickly, like an enlightenment of the individual in few months. Whether if you are treating hypertension or any other of the risk factors, the process is very slow. It may take 4 or 5 years to see some results. And this is basically what the literature is discussing. I'd just like to finish by saying to you that we are excited. And we are excited because this is a new adventure that actually may go into society. First, the issue of technology that is very simple, is affordable. And then the issue of getting into the brain. We don't do this, we should not do these technologies and everybody walking in the street, but the research will tell us where the problems are. And in this case, we're finding the risk factors are important. But I want to say, and I'm not going to discuss because it's not my job today, that to me, the great future is education in children. And we have, at the present time, many trials in 50,000 children, intervene and not intervene. And the data that we have is absolutely fascinating, and I don't have time to get into it. I think it's the age to start talking about risk factors are important, quality of life is important, self-esteem is important, and so forth. I'd just like to finish by telling you at least what I see in 10 years, right or wrong. I see AI coming, but in the prevention of disease, identification of early disease. We are already show a device that is guided by artificial intelligence, but it's much more than the device, it's in general. Preventing health, improving health, and reducing health inequalities. Maybe AI may be interesting on this. And we had a meeting with the fellows, New York meeting a couple of days ago. And when they asked where the future is, I said, this is one of the issues that I feel very strong about it, that prevention AI may be helpful in identification. And the other is the other side of the coin. Secondary prevention, I still think the poly pill will take off. Certainly took off in Europe. We have to see now in the United States with the FDA and so forth. And that is that something very simple, a single pill with a statin, aspirin, and an ACE inhibitor can actually be taken once a day, no more. And the data of the SECURE trial that we participated is very enlightening in this regard and so forth. Well, I think this is my last slide. It's just to say to you that 15 years ago, we changed our gears, science, health, and education, clinical and basic put together, the heart and the brain, and this is actually the way to go. I feel excited, I really do, because in a way, one gets motivated when things are new and things can actually have an impact in society. I personally believe that these imaging technologies that I'm talking about and the concepts that you are evolving and the issue of education in children are going to have an impact in the future. Well, thank you very much for inviting me. Thank you.
Thanks so much, Dr. Fuster, for that excellent presentation, and also sharing with us the breadth of your work that expands from fundamental science all the way to clinical science. So thank you so much. Our next speaker is Dr. Harrington. He's going to be giving the Dr. Valentin Fuster keynote lecture. And I was fortunate back in 2024 when he was a visiting professor here, and I was assigned to him for the whole day. And the topic we did have the controversy. We had the talk. At that time, the topic was optimal medical therapy and intervention in managing chronic coronary syndrome. And from that talk, from that discussion, that sort of inspired my very early project in fellowship. So it's great to have him back. And just to give you a quick introduction for Dr. Harrington, Dr. Bob Harrington is a cardiologist and currently serves as the Stephen and Susan Wise Dean of Weill Cornell Medicine, and is also the provost for medical affairs of Cornell University. His research area is very, very broad, but with a focus that includes assessing antithrombotic therapies to treat acute ischemic heart disease, and also to minimize the acute complication of percutaneous coronary procedures. In addition to that, his research also tries to better understand and improve upon the methodology of clinical research, including the use of technology to facilitate conduct of clinical trials. Dr. Harrington, over the years, has won multiple awards. I'm just going to mention some of them. It was previous American Heart Association president. Even after his tenure, he continues to remain active with AHA as a member of the board of directors. He also an elected member of the Association of American Physicians and the Association of University Cardiologists. And lastly, he's also a member of the National Academy of Medicine. In addition, he served as chair and member of the U.S. Food and Drug Administration Cardiovascular and Renal Drug Advisory Committee. And also, he was named a Master of the American College of Cardiology in 2016, awarded the AHA Clinical Research Prize in 2017, earned the AHA Council on clinical cardiology Distinguished Achievement Award in 2022. And also the same year, it was awarded the Stokes Medal award, and in 2023 had the honorary fellowship in the Irish Cardiac Society. And I think, the most recent award, which I was actually part of that conference, was the Cardiovascular Research Foundation that recognized him with the 2024 Transcatheter Cardiovascular Therapeutics Career Achievement Award. And this goes out to very unique individual, for his extraordinary contribution to the field of interventional cardiology, and also how he's made transformative impact on cardiovascular care through clinical excellence and also pioneering research and mentorship. So I think, there's no other person that, deserves to give us the Dr. Valentin Fuster keynote lecture today. Welcome, Dr. Bob Harrington.
Thank you. That was more than kind. And when Deepak called me to ask if I would come up here and give this lecture, I said, "Well, what do you want me to talk about?" He said, "Well, it's for Dr. Fuster, so something innovative." And I said, "Well, any more guidelines?" And they said, "No, just pick something, and I'm sure it'll work out fine." And I think that's with that kind of direction. I actually thought a lot about this, because you can't show up at Mount Sinai at something to honor Dr. Fuster and just talk about, well, what you always talk about. So I thought long and hard, and I thought, given the audience, where Deepak told me there'd be a lot of fellows, a lot of researchers, postdocs, that I would try to give you a little bit of history using some of the examples from things that I've done over the years in the data sciences, which we all think are brand new, but in fact are actually quite old. In cardiovascular medicine, and try to wrap that around some of the things that we're doing now, including at Weill Cornell. Not to say that it's only at Weill Cornell these things are happening, but they're the examples that I know of best, and we'll try to share those. My consulting relationships. But because we're here to honor Dr. Fuster, I thought, at least in part, what I should do is reflect upon my own journey with Dr. Fuster. And particularly for those of you who are fellows and postdocs, always remember that the people you meet along the way oftentimes really end up mattering to you a lot over the course of a lifetime. Now, I have to say, Valentin, that I was very disappointed to understand that I'm now in the last group of the 60 to 100-year-olds, as opposed to being in the middle group of with the 20 to 60-year-olds. But that's okay. We all get older. But I actually met Dr. Fuster a long time ago, almost 36 years ago, when I was a research fellow at Duke. I was a fellow in something at the time called the Duke Data Bank for cardiovascular disease. And one of the first projects I was assigned was to become the study safety officer for a trial called CARS, Coumadin Aspirin Reinfarction Study. Yes, remember it well, Juan. And my job was to every day oversee the unblinded INR data to make sure there were no safety issues with the trial. But what does that have to do with Dr. Fuster? Dr. Fuster was actually the study chair of this project. It was a very large clinical trial that spanned the United States and involved some very unique attributes of being able to transport whole blood every day to a core laboratory in Los Angeles, where the whole blood INR would be run, and then the results reported back to Duke. Now you'd be like, well, how difficult is that? Well, the only way it could get transported every day was by fax machine, and I would be waiting in the evening every night for the fax to come across to cross-check the various patient listings, et cetera. And I remember from the very beginning that Dr. Fuster took an interest in what I was doing. He was already a very famous cardiologist. I was a cardiology research fellow. And he spent a great deal of time encouraging me, beginning to mentor me, talk to me about my own career. And I'll never forget it. And it's a good lesson for all of us that he would see me then at meetings, and I'd be walking through the hallway, and he would say, "Robert, Robert." And the only two people that call me Robert, well, three, it's my wife, my late mother, and Dr. Fuster. And he would say, "Robert, Robert, stop and talk to me, walk with me." and he would walk, give me advice. In fact, one of the things I was able to do with him, in addition to work together on the cumin aspirin study, was this subset of studies from Gusto 2 on looking at the effects of Hiruidin in patients with unstable angina. And so the reason that I'm here today, and Deepak could have asked me a lot, I love Deepak dearly, but when he said it's to honor Dr. Fuster, I knew that I had to come. So thank you, Dr. Fuster, for everything you've done for me over the years, and including talking me into editing 3 versions of Hearst with him. But it's been a nice journey, and I really appreciate being here. Now, my job is to try to put my remarks into what I'll call the bigger context of why I think that you understanding the role of data science and the role of advanced computation is going to make a difference. And it's going to make a difference, I would say to you, because it has to make a difference. The burden of cardiovascular disease is not less. The burden of cardiovascular disease continues to grow. And for those of you who look at the statistics through work like this in the AHA's annual compendium of heart and stroke statistics, should be humbled by the fact that despite the progress that's been made, and there has been tremendous progress in the way that we care for patients with cardiovascular disease, if we don't somehow make a dent into the pandemic, what the modeled figures have for us by 2050, whether it's looking at the burden from a cardiovascular disease perspective or from looking at it from an economic perspective, are really profound. And so Dr. Fuster's focus, as has been his focus, as he said, for a while, not necessarily on the treatment of cardiovascular disease, but on the prevention of cardiovascular disease, is absolutely critical. We absolutely have to make progress in the prevention of cardiovascular disease, whether that's primordial, primary, or secondary, because number one, the society can't afford the burden that cardiovascular disease will have on society, whether it's from a clinical perspective, a human toll, or an economic toll. And so in the spirit of Dr. Fuster, I'm going to talk to you about 3 things. And the 3 things are that talk to you about the notion that cardiovascular disease, while you typically think about it as a biologic science with anatomy, physiology, etc., I'm going to pose to you that, in fact, that might limit your thinking, and that we need to think more broadly about cardiovascular disease. And I'm going to pose to you that cardiovascular disease is a data science, and that this contains both old and new concepts that I think is really where the difference is going to come, where we're really going to learn insight into both the mechanisms of disease, which are critical to what we try to understand, but also how do we use that understanding through big data, data science, and advanced computation to make a difference, to make new discoveries, sometimes including on old data, to really advance the field. And because I know that there's a lot of people early in their career here, let's talk a little bit about the skills that you're going to need to succeed in this new environment. So again, it's not new. I was pleased to see Donald Lloyd-Jones on as a collaborator with Dr. Fuster, and Dr. Lloyd-Jones is now the new director of the Framingham Heart Study. And the Framingham Heart Study now is very old, and I would submit to you it's our first foray of cardiovascular medicine into the data sciences. That you probably know that after World War II, cardiovascular disease was pretty epidemic in the United States, accounted for, as it does today, almost half the deaths. But there was very little that we actually knew about it from a systematic perspective. And it was the epidemiologic study of Framingham that really taught us about the classic risk factors. I would submit to you that that's the first foray into the data sciences for understanding the fundamental biology of cardiovascular disease. This is where we learned the importance of lipids, blood pressure, diabetes, smoking, dietary contributions in a sedentary lifestyle. And the Framingham Heart Study continues, as you know, today, run out of Boston University, and as I said, led by Donald Lloyd-Jones. My story begins with this in the data sciences in the late 1980s, early 1990s at Duke University with this gentleman, Dr. Eugene Stead. Eugene Stead was the longtime chair of medicine at Duke University, And Dr. Stead had a lot of contributions, but I'm going to cite two, which have a strong affinity to my own career. The first of which is that Dr. Stead was the founder of something called the Duke Data Bank for cardiovascular disease in the 60s. Dr. Stead did something today that you would get in a lot of trouble for. He received one of the original acute myocardial infarction grants to study myocardial infarction. And he said, well, that's interesting, but what I really want to do is buy a computer and start to understand the contribution of all of this individual patient data to subsequent outcomes for the later patients. And so in the late 1960s, Dr. Stead buys this computer, takes up a large room at Duke Hospital, and he forms the Duke Data Bank for cardiovascular disease. And why did he do that? This is taken from a talk he gives in the late 60s, early 70s at the American College of Physicians. Chronic multifactorial disease problems can be studied, but not by the methods of the present or past. If one wishes to create useful information, computer technology must be exploited. Now, if I said that to you today, you'd say, well, of course, that's obvious. This was 1969 that Dr. Stead said this. Just absolutely remarkable. And this was the beginning. This was the records. This is a picture they gave me when I left Duke to go to Stanford back in 2012. This was the original log from the Duke CCU of the patients coming through Duke, where every day this data was extracted and entered by hand into the computer so that they could begin to have the beginnings of a database that would catalog all of the patients who came through Duke Cardiology, to understand who those patients were, what diseases they had, what were their risk factors, and most importantly, what was their outcomes. That Dr. Stead believed from the beginning that the investment had to be made not just in understanding what happened in the hospital, but what happened over time. And the long-term follow-up program from the Duke Data Bank was critical. And throughout the 1970s, what the data bank really focused on was trying to use the tools of observational analyses to take non-randomized data and to begin to draw inference from it. Now, that's very difficult. You can pick up a paper every week and learn about the challenges of drawing causal inference from non-randomized data. The Duke group throughout the 70s and 80s really focused on the methods of trying to understand how to do that. What were the mathematical issues that had to be applied to non-randomized data in order to understand what was the benefit of bypass surgery versus medical therapy? What was the benefit of coronary intervention, percutaneous coronary intervention versus bypass surgery? And how would you do that? What they began to do is create something called the prognostogram, which when you would do a cath at Duke, and you would enter as a fellow the data into the data bank. That was one of your roles as the fellow throughout the 70s, 80s, into the 90s, late 80s, 90s when I was a fellow at Duke. And you would literally press a button on this enormous computer, and the computer would spit out a prognostogram that would say, for patients like mine, what were the observations in the Duke data as to how those patients fared? And you could understand, based on that patient's demographics, their historical features, how they presented with their disease, was it an acute MI or was it stable angina? And then you would get a listing of what risk factors they had, et cetera. And then you would get an outcome over the next 1, 3, and 5 years as to what happened to 100 patients like yours who underwent bypass surgery. What happened to 100 patients like yours who underwent percutaneous intervention or who were treated with medical therapy. And this was an enormously valuable tool as all of us were learning how do you talk to patients about informed decision-making. And so these ideas that we talk a lot about today actually have their roots many decades ago. In fact, this is a great editorial written by Rob Califf and Bob Rosati in 1981 called The Doctor and the Computer, which was reflecting upon a project coming out of Seattle and talking about how do you use aggregated data from a single center in order to make inference into new patients that might be entering the system. And you can see how Dr. Califf and Dr. Rosati end their editorial. In the future, data banks will provide a reference library for each patient with chronic disease. But proper interpretation and use of computerized data will depend as much on wise doctors as any source of data in the past. And I want you to keep that in your brains because I think they were foretelling what was going to come many, many decades later as we begin to get more familiarity, more facility with data. Something else that Dr. Fuster always has insisted upon, and he mentioned it in his talk, was the bringing together of diverse groups of people with different experiences, different backgrounds. How do you mix the basic scientist with the clinical scientist, with the people who do population health? And how, as you've done here at the Fuster Heart Hospital, how do you bring that together in a way that really allows you to solve big problems? Dr. Califf also had that sort of vision that he got from his mentor, Dr. Stead. This was a picture, the 25th anniversary of the data bank. I had just joined the faculty of the data bank. See if you can pick me out of this picture. There's a lot of people in here that some of the older members of the audience will recognize. Dan Mark, Magnus Oman, Kerry Lee, Dr. Califf. But one of the things I like to point out in this picture is that there are clinical cardiologists, interventional cardiologists, imaging cardiologists, biostatisticians, epidemiologists, computer engineers, people who study health and quality of life outcomes, health economics, quality of life outcomes. And so one of the things to keep in mind as we begin to think about putting teams together with all the rich resources of data is that you need diverse teams, people from different backgrounds, different experiences, different ways that they look at a problem if we're going to tackle big problems together. You know, a problem is important from a societal perspective if it makes the cover of The Economist. And in fact, this notion of big data, data science, has made 2 covers of The Economist over the course of the last 15 years or so. The first one was called The Data Deluge, in which case they said that all of the data, all of the great advances, no matter what business you're in, are going to come from understanding data. And there's data everywhere, so to speak, and hence the visual of data pouring down on an umbrella. The second article, the second journal of The Economist that was devoted to this was when it deemed that data, not oil, was now the world's most valuable resource. And if you think about the companies that have evolved over the course of the last couple of decades in the US and Europe and China, they're really largely built around data and access to data, your ability to pull data together and make sense of it. And that's where I want to go in getting you to think for the future about what's important in this notion of data science. What actually is data science? And why do we talk about this so much today if we've had this background in cardiovascular medicine of things like Framingham, of things like the Duke database, and I could list a number of other large data sources that people have collected and curated over the course of the last few decades. But we're at a very unique time because what data science actually is, it sits at the intersection of computing, of math, and of the domain knowledge. Not one of those by itself is going to be able to make the difference. It's when you bring all of it together, when you bring the statisticians together with the computer engineers, with the clinicians, that's where the real magic comes of being able to make sense of these large amounts of data. And why does it matter now in 2026, whereas back in the days when I was a fellow in the data bank, it was much, much harder to do. We've had a large amount of data for a long time, but now we have data, it's literally everywhere, and everything can be turned into zeros and ones, including images, pathology slides, EHR data. How do we do all of that? Advanced analytic methods aren't really new, AI and machine learning. I'll show you some examples of this going back decades now. It's really cloud computing that made the difference. The ability to really analyze big amounts of data in ways that previous computing power couldn't do. When I was a young faculty member at Duke in the Duke Data Bank and then ultimately in the Duke Clinical Research Institute, when we had complicated analyses on large data sets to run, and I'm talking about running pretty basic stuff, multivariate analysis, we would literally network all the computers on one of the floors of the research building, tell people to leave their computers on overnight, and then run the analysis overnight. Now you can do these analysis that we did that way on your phone. in a much, much, much more sophisticated way. It's cloud computing that made the difference, and that's why it's only been in the last few years. So here we go today. Medicine is, in fact, a data science. And look at the sources of data we have: clinical data, public health data, imaging data, administrative data, weather data, climate data. I mean, all of this can now be brought together. One of the beauties of artificial intelligence is that it does allow you to work across disparate forms of data. Previously, again, the more senior clinicians will remember this, we had to look at things separately in different bins. We had to look at the imaging data. We had to look at the genetic data. We had to look at the clinical data. And we would try to link it and make inferences across these different buckets of data. Now we have the tools to look at it at the same time and do analyses across the different disparate ways of looking at data. I went to Stanford in 2012 from Duke and became very engaged with a group of the informaticians there. One of the reasons I actually went to Stanford is to be able to hang out with the computer scientists, the informaticians, the mathematicians, to be able to really understand, in this new world of clinical investigation, how do we tap into the wealth of data we have. And two people that I really enjoyed learning from were two informaticians, Chris Longhurst and Nigam Shah. And about a decade ago, we wrote this paper as a thought piece for academic medicine, for health affairs, called "A Green Button for How to Use Aggregated Patient Data at the Point of Care." And this was a thought that we had. How could you basically, at the point of care, do what STED wanted us to do, which is to, quote, press a button, end quote, and learn about your patient and the characteristics that they had and how we treated them and how we might treat them better. One of the things at Stanford Healthcare was that they were enormously supportive of trying to understand this. So the healthcare system actually allowed us to create an informatics consult service where anybody who was making rounds, and this was oftentimes fellows, residents, students, they could ask a question of the Green Button team. And that question could then be put into the language of the computer, and we would search large amounts of data to provide back at the point of care some answer to a question you might have had, which is, look, my patient doesn't fit the guidelines. My patient is not somebody who's been studied in the clinical trials. What do we know about my patient? What do we know about how things have turned out for patients like mine? And what do we know about potentially what might be the best treatings? Now, this isn't randomized data, and there are limitations in that. But in some cases, it's the best data we had. In fact, I would say that for most clinical decision-making in medicine, it's the best data that we have. And so we did that and have published a whole series of papers on that. But we also knew that you had to be able to collect data really at scale. And then as you collected data at scale, how might we then also think about randomization? So one of the first opportunities we had to really collect data at scale was in a project with Apple. Apple at the time was developing their Apple Watch to be able to detect atrial fibrillation or detect some signal that had a high probability of being atrial fibrillation. And so we embarked upon a large-scale project with Apple to try to understand a couple things. And I think the most interesting thing that we tried to understand is, could you get people at scale to give permission to allow you to access their health data through something that they were wearing? Now, today, that doesn't seem so hard. In fact, it was very hard to figure out, could we get people to do this? But we did. And this is now 2017, 2018. And we enrolled over 400,000 individuals, only project I've ever been involved with that enrolled patients in every state of the United States. And we didn't just enroll what I would call the typical Silicon Valley type of a young software engineer. Instead, we enrolled a lot of people over the age of 65, people with a lot of cardiovascular risk, people with previous cardiovascular diseases. And so while the Apple Watch component of it was interesting to understand, could you pick up atrial fibrillation with a high degree of positive predictive value? The answer is yes. But I thought what was more interesting is you could actually get people to give you permission to use their data to answer interesting health questions at scale. But as we were doing this work, always in the back of our minds was this notion that if you really want to, that's great to understand risk factors and the way we might take care of people. But if you really want to understand therapeutics, you had to be able to randomize. This goes back to work done by the Oxford groups over the decades, which wrote this editorial that says there is simply no serious scientific alternative to the generation of large-scale randomized evidence when you want to understand A versus B. And because in cardiovascular medicine, most of the differences that we're going to find are actually relatively modest. They're important because of the scale of the disease, but they're modest. And we need to therefore use large sample sizes to be assured that the effect is a real one. And so how are we going to do that? Well, with the experience of using data at scale in the electronic health records, the experience of being convinced that patients will give you the ability to get their information through devices, we've embarked upon a whole series of opportunities to do randomized clinical trials within the electronic health record, where we can actually scan through hundreds of thousands to millions of records to try to understand how do we then collect that data in a systematic way. How do we then get people to give us consent to randomize them to a therapy or technique or diagnostic approach, and then learn something that might actually benefit, as Deepak said, human health. Well, the first big scale study that was funded by PCORI to do was something called Adaptable, the comparative effectiveness of aspirin dosing in cardiovascular disease. This was trying to answer that question that I'm sure has always bugged you. Is it 81 milligrams of aspirin or 324 milligrams of aspirin that's the preferred dose if you have coronary heart disease? Well, we answered the question in about 15,000 subjects who we culled from about 500,000 people that we approached through the electronic health record to ask them if we could randomize them. And the punchline is it doesn't matter. You can use 81 or 324, and you get similar outcomes, and whether it's on the bleeding or the efficacy side. But again, less important was the question. More important was the fact, the methods, that you can now do this at scale. Well, there's now people looking at doing this at scale, including the Heart Association, who through their guidelines program have millions and millions of patient records through the electronic health record, working with well over 3,000 hospitals to try to understand this. About 80 to 85% of all stroke patients, for example, are captured in Get With The Guidelines. And it's become a way to think about how do you do clinical trials, for example, in Get With The Guidelines or with NCDR through the ACC. And all of those experiments are starting to be done, where large-scale randomized trials are going to be done within the registries, within the electronic health records, to try to answer important questions. Here in New York, you participate along with us in other academic medical centers in New York in a PCORI project called Insight, where millions of patients of records have been brought together from all of our hospitals, put through a common data model, and have access for researchers to begin to ask observational questions, but I think more importantly and more interestingly, to try to ask questions that can be best answered through randomization. And there's a lot of data here in New York through the Insight Registry that, as you think about the kind of clinical trials that you want to do, the kind of clinical studies that you want to do, these data are in fact available. And it's not just through the electronic health record. Now, through work of the Insight investigators, other types of data have been added in, including things like weather data, cellular phone data, where you can begin to really understand different types of behaviors, et cetera, and how that might impact upon human health. Well, having all of that data then now leads to the idea of, well, what are the best methods for analyzing that data, and what are the best methods for making good use of that data? And then we come to this notion of how do you partner data science with advanced computation, including machine learning, artificial intelligence. Well, I always like to point out that these are not new ideas. These ideas go back, although we talk about it all the time now, this goes back into the 50s and 60s, where radiologists in particular were beginning to use artificial intelligence to interpret images But what was the limitation? The limitation was the fact that not everything was collected in a standard way. DICOM had not yet existed to standardize the way that images were collected and transferred. And cloud computing did not yet exist. And so you didn't have the computational power, if you will, to be able to analyze large amounts of data. While I was at Stanford, we tried to bring these two things together. We created a research center for artificial intelligence and medicine under Kurt Langlott's leadership, and we established a data science unit within the School of Medicine to be able to work collaboratively across different disciplines with different types of clinicians, computer scientists, engineers, biostatisticians, epidemiologists. So once again, those lessons learned from the data bank decades before were really important today. And a lot of work began to come out of using those teams in the data science realm, using the teams in the artificial intelligence realm to begin to understand how to use different types of data to answer questions relevant to human health. Well, we learned important things along the way. It was a paper from two members of our department at Stanford that pointed out some of the limitations of thinking you can just go out and pluck large amounts of data and try to use the tools of large language models and artificial machine learning, artificial intelligence to answer questions. One of those limitations was that the data wasn't representative. In this particular analysis, looking at machine learning in diagnostic imaging, they realized that something like 16, 17 states in the United States had not contributed any of their data to these large national data sets. The data largely came from California, Massachusetts, and New York. Why is that? Because that's where the academic medical centers with a lot of NIH funding seem to exist. And guess what states weren't represented? The Southeast, the Southwest. And what does that mean? It means that the population wasn't representative of the United States. And you can see the same types of analysis have been done around the globe in terms of where the data comes from. And that has gotten people really thinking about if you're going to utilize the data sciences, if you're going to utilize the tools of things like artificial intelligence to answer questions, you need to be thinking holistically from the moment the data is generated to the moment you're using it to create a model and then to make some pronouncement about how that model behaves. You want to make sure that data, in fact, is representative. You want to make sure that things have been created fairly so that all people are represented. And these are things that there's a great deal of research going on. I've been thinking and talking a lot about this with different groups over the course of the years, and here's a few of them. But one I'll call your attention to is I recently interviewed Bob Wachter, the UCSF chair of medicine, who's written a book called The Giant Leap, which, if you've not read it, is a terrific introduction to the use of artificial intelligence in healthcare. And Bob really is a very forward-thinking. About a decade ago, he had written a book called The Digital Doctor, which is the advent of digital technologies in the healthcare setting. And maybe the central figure of that book, which I've not forgotten, is the notion of what we've lost as radiology rounds disappeared, because we can all look at the images on the computer as we walk around. But we've lost that ability to be able to connect with each other in front of the image as people from different backgrounds talk about cases, et cetera. And likewise, in The Giant Leap, he talks about where he wants us to have a cautionary tale. Now, he is very bullish on AI in healthcare. And I think one of his statements from the book that stuck with me is that done well, AI will replace tasks of doctors, but won't replace doctors. Now, think about that, and is that could be a good thing? That may not be such a good thing, and I think it's going to be up to all of us to create a world where it will be. Let's see if we can. Here we go. And one of the reasons I came to Weill Cornell is the ability to really think about these issues of artificial intelligence. We have a great engineering school at Cornell in Ithaca. We have a great computer science school in Ithaca. We have a technical campus on Roosevelt Island where a lot of graduate work is being done in machine learning, artificial intelligence, engineering, and how do we put that all together with a great ecosystem in New York City of healthcare to answer these kind of questions, just some of the collaborations we're able to tap into. This is now forming a key part of our strategic plan at Weill Cornell Medicine to really advance research, clinical medicine, education through the powers of artificial intelligence. And so everything we're doing at Weill Cornell is seen through this lens of the three missions really supported by the data sciences and artificial intelligence. And I think about often papers like this by Tom Frieden, the former director of the CDC, that really says we have to have new ways of looking at data and at questions, because not everything in medicine is going to be answered by a randomized clinical trial. People like Deepak, Greg, and me would wish that it were, but it's not the case. And we're going to have answers to provide to all of us daily at the point of care, taking care of our patients. That has to be the next level of evidence. And a lot of that is going to come from our ability to tap into large amounts of data and analyze it in appropriate ways. Just a couple of things that different people in our group are working on, and I know with people here in collaboration at Sinai, long COVID phenotyping done through the Recover granting mechanism through the NIH. Fei Wang, who's our new Associate Dean for Artificial Intelligence, has done a lot of work of trying to understand what are the best chemotherapy choices for patients with different types of cancers, in this case, bladder cancer. Looking at optimal therapies, including reusing of old drugs for treatment of things like Parkinson's disease. And we have the advantage at Weill Cornell of also having a campus in Doha, Qatar, where there's a lot of really interesting engineering work being done, for example, in understanding sensors in the population and how to tap into that data combined with clinical data to answer questions. And this is just one of their many papers. I think there's going to be, again, looking at Deepak and Greg, there's going to be a huge call for the use of artificial intelligence in clinical trials. And one of our former fellows has been able to put together this viewpoint in Jack recently about how we might do that. A lot of people are doing this, target trial emulation, trying to simulate clinical trials. I see this not as the answer, but as the prelude to whether or not that hypothesis is worth testing in real human beings to get a definitive answer. But the other way that we're beginning to look at this is, can we do a better job of planning for trials by using AI in clinical trial design and using different agents, AI agents that can tap into large amounts of data, create these clinical trial emulations, and begin to feed back to us from a hypothesis generating perspective that in fact this might be reasonable. And we have a group led by Judy Zong, who we recruited this past year from NYU, the Clinical Coordinating Center, to really think about, okay, how do we use AI agents for clinical trial execution? And could we, for example, take out some of the human element, particularly of those tasks, as Bob Walker would call them, that could be replaced by AI? And there's some fascinating work that she's doing in having DSMBs really largely be run by AI agents who can constantly surveil the data in a way that is consistent with the desires of the human clinical trials investigators to make sure that the data are being monitored. There'll be no more waiting, Greg, for the data to catch up because the AI agent is constantly looking through it and constantly analyzing it in a way that you've already programmed in what you're looking for, what you're worried about. And we're going to have a paper on this coming out pretty soon. This is just one paper that I've been involved with recently, and I know that several in the room have also been involved with different data sets of using AI to take away this very human-intensive activity of doing clinical events adjudication, of looking at clinical events and clinical trials can now largely, I think, be done in a pretty good way by using AI agents, and I think you're going to see more of this. Final thing I want to close with, particularly for the young people, is what I'll call the skills that you need to succeed in the coming world. And I always go back to Dr. Stead when I really need some people that had the original ideas. And Stead loved to say about education that it's what you have left after you've forgotten the facts. And he would say that there are those who wander around the wards and there are those who are doctors. The difference is in having the data. And I think that while he said this in the 70s and 80s, this remains very true today. Hopefully you've not had this happen to you where somebody says our statistician will drop in and explain why you have nothing to worry about. But what it points out to me that if you're going to succeed in the coming world, you really do have to, if you want to be a clinician, you do have to have development of the computational part of your brain. You really need that piece of your brain developed if you're going to succeed in the coming world. At Stanford, we called this the rise of the data-driven physician and spent a great deal of time thinking about this. And in our own medical school at Weill Cornell, we're beginning to think about how do we really embed artificial intelligence into what we're doing. And by that, I mean beyond open evidence, certainly using open evidence as a great tool. There's a great stat out now that without very little marketing, open evidence is now being used by the majority of clinicians in the United States. Because we're all hungry for this kind of information and this kind of interaction. Well, how do we make sure that our trainees know to do this? So we have a whole series of questions that we're guiding our medical school through to try to understand what AI competencies do we want our graduates to have? How can we use AI to improve patient care? How do we incorporate AI into their learning? And we're doing some really interesting work with the Ithaca campus with avatars and artificial intelligence for patient simulations, where you can, instead of using real patients for patient simulation, you can actually use AI agents that will mimic for you a variety of clinical opportunities. And how do we get our faculty and our students thinking about AI-focused education? Now, I don't exactly believe this, that I can't wait till technology replaces doctors. Medicine will be so much easier and better once the engineers are in charge. In fact, we've written a paper about this with Abraham Verghese, the author who I suspect some of you in the audience know, and Nigam Shah, that we called in tribute to Dr. Stead, who used to always say, you know what this patient needs? This patient needs a doctor. And we titled this, What This Computer Needs is a Physician. And it's really trying to, how do we all think about these amazing tools that are coming along in the data sciences and artificial intelligence, but how do we wrap around with that the humanism that's so important in the practice of medicine and the art of medicine to make sure that our patients are getting the best evidence-based care, but with a sense of humanity around it. So Deepak, Dr. Fuster, thank you for having me. It's been a privilege to be here, and I'm happy to answer questions, Deepak, if you like.
Well, first of all, I guess I feel bad because I really put you to work. I didn't necessarily need for you to put together all the talk, which you clearly did, really outstanding, inspiring, and futuristic, really perfect for the venue and the
And to celebrate
celebrate Dr. Fuster and all the trainees as well that are in the audience. It's just amazing. You quoted Eugene Stead a few times, and I remember hearing a quote from him as well, that, whether it's data we don't need subspecialists because there's data, the interest or whoever's handling the patient can do it. And I think it points to the central importance of data. You touched upon some of the things that AI might do in terms of clinical trials, for example, the adjudication process, the DSMB process. I think there's a lot of learning that can be done by AI. I think might be the role of future trial design and implementation, specific adaptive trial designs in using machine learning. There's been some work in that area right now, as you of course aware, participating trials can be adapted based on event rates, increase the sample size, enrichment, look at a subgroup like positive patients, enrich that subgroup. But then, with machine learning, there's the potential to identify multiple different characteristics beyond what a human brain might have been enriched for those. Folks at Yale have been working on some of those models, rolling carrying out. Any thoughts about how those aspects of AI/machine learning could inform clinical trials design and implementation?
So a great question. I'll say a couple things, Deepak. One of which is that last year I had Rohit's paper on phenomapping as one of my favorite papers of the year because of the role that it could play in adaptive trial designs. And you and I were co-authors of a paper about 15 years ago now on adaptive trials and the type 1 error issues associated with adaption. And you very rightly pointed out that we, in our roles at the time, had pre-specified some subgroups that would be looked at. What Rohit's talking about is that you don't pre-specify anything, that you let the machine find it by creating phenomaps of different groups and finding where where the treatment benefit might be emerging, and then shunting randomization independent of the investigators to those groups. I think it's a great topic that we should be thinking more about, because we've all done studies that at the end, the result maybe is marginal. And then you see a group that, like, wow, there's a group here that looked like the benefit is really there. And then what do we have to do? We have to do another study. And what Rohit's trying to talk about is, could we avoid that? Now, I think there's a lot of issues, a lot of statistical issues around the preservation of the type 1 error and false positives and all of this stuff, but I do think it's very promising, and I've been trying to get somebody to do it. It's going to take some time, but I love the idea. I do think there's a role for it.
Great, thank you.
I have a question. Well, actually, I think it was Nature Medicine or Nature a couple of 2 weeks ago. They made the point, and I think you mentioned that investigators are becoming more isolated. I think this is a problem. And that if you get a subject, you're yourself, AI is going to be helpful. But there's something else. The amount of science that is going to be developed will be more restricted because of that. What is your opinion? Because this is
Yeah, I still believe, and it's one of the reasons I brought out bringing groups of people together, that you do need different viewpoints, expertise, et cetera. I believe very passionate about that. I also be very passionate in having meetings like this where we get together. Zoom is great, but having people in the same room talking to each other, I don't think there's any substitute for that. And while the tools might be getting better, there's no substitute for human beings talking to one another.
We're right in schedule, so we'll take 1 or 2 questions from the audience for Dr. Harrington.
Bob, that was a fascinating talk. Thank you. A lot to think about. So I agree, wholeheartedly with your suggestions about the use of AI to make randomized trials more efficient. ESNBs, CD4 laboratories, and other processes. What I want to ask you about in general is your current beliefs about, can big data replace randomized trials? So let me give you a little context. About 35 years ago, when I was a young physician, I spoke to Eugene Grunwald, who appropriately talked about it. And he basically, one of the first randomized trials came out, and I spoke to him about it as a fellow. He basically said, well, this is really difficult and very expensive. We're not going to be able to randomize it. And then about 8 years ago, I was speaking to him about this topic, and he said, every important question must be randomized. And obviously, everyone knows the advantage of randomized trials, getting rid of confounding. That's number one, front and center. So now we've got, but they're very expensive, very inefficient. Now we've got big data. And I'll just give you one example of my most recent experience, which also relates to a discussion I just had with Mario Godino, cardiac surgeon and your associate dean of clinical trials. Jack right now has a great paper that's out in the press on looking at single versus multiple bacteriographic in biochemistry.
Came out yesterday.
Yeah. Just there's a difference with survival from multi-bacterial. In using instrumental variable analysis, there was no difference. I spoke to Mario about it, and he basically, didn't believe it, and his preconceived notions were one way. It doesn't even matter which way it was. But the point is, if we don't randomize, are we going to have questions about, based on your preconceived notions, based on when you see outcomes that don't make sense to you, that you're going to tend to discount that data. Whereas if you believe that that was what's going to happen, then you're going to tend to believe it. In contrast, when we had a big, well-done randomized trial, that tends to convince most of the skeptics.
So are we going to get to this place where we can use big data reliably enough to replace randomized trials and then get the benefits of being able to detect those small to modest differences that you described?
I don't think so. That I've been invited to a lot of meetings, I'll call it as the sacrificial clinical trialist, where the topic of the meeting is drawing causal inference from non-randomized data. And there's no question things like instrumental variables, that as a technique has improved the way that we think about, leveling the playing field, so to speak, to try to reduce confounding. But you'll never get rid of it completely. And so I think as trialists, one of the obligations that's on us is to figure out ways to make trials simpler, to make them more efficient. And that's why I'm really bullish on using AI agents, Greg, not so much to search for the non-randomized answer, like clinical trial emulation, which, by the way, is a terrible name, but to really make it more efficient. Because if we could, that I think is the issue, right? Even the observational folks would say, well, if you could answer the question in a randomized trial, of course that's better, but you can't. And that's where I think Frieden gets at in his article about, what he calls like the dark matter of medicine. There's all this stuff that even in our field, what is it, 70% of the guideline recommendations are class 2? So I think it's on Deepak, you, me, trialists to say, how do we get better at this? And how do we make it more efficient? And that's usually my answer. After I make fun of observational analyses, then I say what we really need to do is get better at doing clinical trials.
Thanks.
All right, thank you. So it is now my pleasure to introduce Dr. Eric Nestler, who I think is here. I saw him walk in earlier. Oh, there you are. Okay. So Dr. Nestler is the Dean of the Icahn School of Medicine at Mount Sinai, an extraordinary scientist, a neuroscientist who's really had sort of landmark papers and contributions in neuroscience, and a member of the National Academy of Science. And there was a celebration recently. And a dean of our school with a really big vision, a fantastic dean. And so we welcome you to the Fuster Heart Research Forum today, and we are excited to hear about your vision for research at Sinai. Welcome.
Thanks a lot. Good afternoon, everyone. It's really great to be here and great to see such a large audience. Bob, I'm so sorry I missed your talk, but a big thanks to Bob Harrington, Dean at Cornell, for joining us today. Let's give him another round of applause, please. Thank you. I was actually at a thesis defense for one of my own PhD students, so I did have a good reason not to be here. It is so good to celebrate where cardiovascular research is today. I'm a psychiatrist, and I have to say that I'm very envious of the advances that I've seen in cardiovascular biology and pathophysiology over the last decade and more. The precision with which you all as a field have identified the mechanisms of disease and novel ways to attack those mechanisms to help our patients is really unprecedented, and I think represents a paradigm for the way the field needs to proceed. All fields in medicine need to proceed in the years ahead. One of the things that I've also been impressed with over the last few years is how, in contrast to the way we all in my vintage trained in neuroscience, cardiovascular biology, cancer, and so on, fields that were relatively siloed and separate, we thought our disease pathophysiologies were quite distinct from one another. We're now learning that every organ, not surprisingly, is interconnected, and many of the researchers that we have here at Mount Sinai in the Cardiovascular Research Institute at Mount Sinai Heart are very interested in the interplay between how the cardiovascular system controls brain health, and in turn also how the brain controls cardiovascular health and disease. So looking forward at Mount Sinai, and Cornell, I'm sure, is in the same boat. Where this has been quite a 15 months we've been through, right? We've certainly been challenged in ways that many of us never thought we would be. On the other hand, I would venture to say that the worst thing we have is the fear and concern and anxiety, as opposed to the actual tangibles of the way the research enterprise has been proceeding. I'm harking back to what President Roosevelt said during the Great Depression: the only thing you have to fear is fear itself. In many ways, if we look back a year ago today, there were proposals to cut the NIH budget by 40%, to cut indirect rates to support research infrastructure at universities down to 15%. That would represent a 75% cut or something like that at many of our institutions. Many people's grants were not being funded. Those that were funded were rescinded, actually. Unprecedented for that to happen. But here we are a year later. Every dollar that was allocated in 2025 to NIH, which was the same as 2024, got out the door and went to the extramural community, right? There was no rescission. Indirect rates were held constant. Mount Sinai renewed its indirect rate for another 4 years till 2029 at 68%. The 2026 budget for NIH has a 1% increase over 2025. Many of the grants that were canceled were restored. So here we are a year later, and I know many of you probably are sitting on really good grant scores and wondering when your grants are going to be funded. They will be funded, because once again this year, every dollar allocated by Congress to NIH will get out the door to the extramural community. So you got to be strong, perseverant, and I am confident that we will prevail as an institution, but really as the biomedical enterprise in the United States. So looking forward at Mount Sinai, Cornell, and other medical schools in New York and around the country, the goal is to use these amazing resources that the taxpayers choose to give us through Congress, more money to NIH today than ever before, right? Let me repeat that. More money to NIH today than ever before. It is our responsibility to use those dollars wisely. So that means to be innovative and creative and bold and propose your studies that will really change the world, from most fundamental biology to advanced translation into the clinic and into the community. So I'm going to stop there and let you get back to the real business of talking about cardiovascular research. But thank you again for having me, and keep up the great work that you're doing. Thank you very much.
Thanks so much, Dr. Nestler. Now we're going to be moving on to the next segment, which is very exciting, to showcase the work of the future of cardiovascular disease research. And we're going to have 6 oral presentations by trainees. We'll have the first 3 now. But just to give you perspective, we received over 130 unique submissions. And among those 130 submissions, we selected 6. And this was not done by the committee, but we had rigorous faculty review from basic, translational, and clinical faculty to review those abstracts. And among that, we're able to select 6 top abstracts, and those folks are going to be presenting their work today. To start us with would be Dr. Minel Soror. She is an advanced cardiac imaging research fellow at the Mount Sinai Fuster Heart Hospital here. She completed her residency and general cardiology fellowship at Hospital Universitario Centro de Asturias in Spain, and subsequently pursued an advanced training in echocardiography and valvular heart disease at the Hospital Universitario 12 de Octubre in Madrid. Our current work focuses on multimodality cardiovascular imaging, and I've had the opportunity to work with her in a doing our imaging rotation, with particular interest in cardiomyopathies and valvular heart disease. She's been awarded grants from the Spanish Society of Cardiology and also the Alfonso Martin Escudero Foundation to support her research. Today, she's going to be presenting her work, which is entitled Splenic Extravascular Volume Mapping, a simple CMR tool to differentiate AL and TTR cardiac amyloidosis. Please welcome Dr. Soria.
Thank you very much for the invitation. Lucky me to speak after all these giants of cardiovascular health. I will try to do my best. Today we'll be presenting our work titled Splenic Extracellular Volume Mapping, a simple cardiac magnetic resonance tool to differentiate AL and TTR cardiac amyloidosis. This project was led by Dr. Binstock and Dr. Lerakis, whom I want to thank for the guidance and support. The author report no conflicts of interest related to this work, and here you have the information for my research grant for this project, and also Dr. Musavi's research grant for her stay. Okay, so we all know that cardiac amyloidosis is a progressive infiltrative cardiomyopathy primarily caused by immunoglobulin light chain and transthyretin amyloid deposition. Distinguishing between these two types of amyloid is critical for guiding prognosis and therapy. There are other types of amyloid disease, but these two are the main causes. And in recent decades, CMR has revolutionized the non-invasive diagnosis of cardiomyopathies, including cardiac amyloidosis. Specifically, parametric imaging is a technique that allows us to assess tissue alterations in the hearts, such as infiltration and fibrosis. Several studies have attempted to distinguish AL and TTR amyloidosis based on cardiac findings alone, and although we know how to diagnose cardiac amyloidosis, to make this distinction by CMR is still a task that we have to develop. So when we try to look at the heart, several studies have attempted to identify key differences in cardiac mapping parameters, but to this date, there is no simple CMR parameter that can reliably distinguish between these two types. So that's why we decided to look beyond the heart. And in our mapping sequences, we also normally imagine the upper abdomen. So one key distinction between these two types of amyloid disease is the pattern of organ distribution. We know that AL amyloidosis has frequent infiltration of reticuloendothelial organs such as the liver and the spleen. In contrast, although TTR amyloidosis often presents with extracardiac manifestations, involvement of the liver and the spleen is uncommon. As I said, on our routine mapping sequences for CMR, we usually image the upper abdomen. So we investigated whether a spleen and liver ECV mapping derived from CMR studies could aid in distinguishing those two types of amyloidosis. We retrospectively analyzed 136 patients with cardiac amyloidosis who underwent CMR with native and post-contrast T1 mapping between 2018 and 2026. For tissue mapping analysis, regions of interest were traced in the spleen and the liver, as you can see here, using a basal short-axis myocardial slice acquired during routine CMR studies. Then we performed a ROC curve analysis. Our result shows that, consistent with prior series, TTR patients were more frequently older, male, and had a higher prevalence of hypertension or dyslipidemia. We did not find any differences between the groups regarding diabetes, atrial fibrillation, or coronary artery disease. Regarding the parametric analysis, we did not find significant differences in hepatic or splenic native T1 times. However, median spleen ECV was significantly higher in AL than in TTR patients, whereas liver ECV showed no significant differences, as you can see here. We performed ROC analysis demonstrating excellent discrimination of AL from TTR using a spleen ECV with an area under the curve of 0.87 and a cutoff of 33% yield a sensibility of almost 91% and a specificity of 75%. So our conclusion is that our studies show that spleen ECV effectively differentiates allele from TTR cardiac amyloidosis, capturing differences in systemic organ involvement. We propose it as a simple, non-invasive biomarker during routine CMR studies, and these findings warrant prospective validation in larger cohorts. I also want to thank our technologists, Frank Macaluso and David Lee, for the exceptional support and expertise, and I will be glad to answer any questions you may have. Thank you so much for listening.
All right, we'll take one or two questions for Dr. Surya.
Have you guys, thank you for presenting this work. Have you guys looked for, like, trying to validate this on another population of people or another amount of studies, or is this primarily a retrospective analysis so far?
Yeah, so far we are increasing our sample, and also we are collecting, trying to validate like the normal range of ECV of in the spleen and the liver in healthy subjects. There's data that we in another centers that have shown like normal ECV mapping for the spleen and the liver, and it has been also used for AL amyloidosis only, not as a diagnostic tool to differentiate both of them. So as currently we are trying to have like our own data for healthy subjects, and then yes, that will be the next step. Thank you.
Thank you so much.
Thank you.
Hi, everyone. My name is Dr. Abby Yates, and I'm one of the organisers for today. And it is my pleasure to introduce our next speaker, Dr. Thomas Ratner. Dr. Ratner obtained his medical degree from the Medical University of Graz, Austria. His previous research centred around immunometabolism in cardiovascular disease, and he joined the Swirsky Lab with a Max Kade postdoctoral fellowship, awarded jointly by Max Kade Foundation and the Austrian Academy of Sciences in 2025. So please welcome Dr. Ratner.
So thank you for the kind introduction. I'm Thomas Ratner. I'm a postdoc in Phil Swirsky's lab at Cardiovascular Institute, and today I'll present IL-3 is associated with cholesterol and cardiovascular disease in humans. Our disclosure with provisional patent application concerning this matter. So to start with, we were very interested about the role of interleukins in cardiometabolic disease. And what we did, we took a look on the genetic association of interleukins with cardiometabolic disease, as well as some other inflammatory disease on the left side. And what you can see, that there are not that many associations at all. For example, take a look in the second row, interleukin-1 beta, very commonly known for the CANTOS trial, because there the inhibition of, or targeting of interleukin-1 beta proved to be very beneficial in atherosclerotic disease, but we couldn't see any association there. If you go the rows down, you can find interleukin-3. And what you can see here, you have an association with BMI and cholesterol, and that led us to go further down the road. Let me briefly introduce interleukin-3, was the first discovered interleukin, also known as multi-CSF. It has a unique alpha chain receptor, which we'll come to later, and shares a common beta chain receptor of interleukin-5 and GM-CSF. And the traditional role was thought to be played in the bone marrow activation. So from the genomics data, we went to transcriptomics. We utilized Jason Kovacic, who was also faculty here at Mount Sinai, STARNIT database, and took a look into patients with coronary artery disease and without. And what we could see, that the interleukin-3 expression in their order significantly correlated with the extent of coronary artery disease. You can see the 4 parameters on top. And the interleukin-3 RA expression also significantly correlated with the extent of coronary artery disease. But let me emphasize where it was. It was in the white adipose tissue. This gives us hints that we have some inter-organ communication involved. So from transcriptomics, we moved to proteomics. We queried the Nightingale UK Biobank, where we have some access to proteomics data from plasma from a lot of patients. In fact, about 40,000 patients had some biochemistry available. And what we could see, we took a look on LDL and HDL related measurements and correlated them with cholesterol. So we have a huge array of measurements, and the correlation was very striking. You could see a significant positive correlation of interleukin-3 levels with all LDL-related measurements and a negative correlation with all HDL-related measurements. This finding we wanted to verify. So we went to our in-house biomed database, where we checked 60,000 patients and selected patients or excluding patients with confounding disease or medication. And we measured interleukin-3 levels in those samples, and what we could find, a very similar finding, interleukin-3 levels go up in patients with high cholesterol, both total and LDL cholesterol. This leads us to our first conclusion, which is, in humans, interleukin-3 increases in tandem with LDL and total cholesterol levels. But now the question is interleukin-3 disease promoting or just a marker? We went into the literature and searched for studies where interleukin-3 has been actually given to patients. We could identify, in the end, 2 studies which both treated the patients and reported cholesterol levels, and what we could see that interleukin-3 lowers cholesterol. The intention of those studies were in no case into cholesterol lowering, but the poor hematopoiesis effects. They tried to treat patients in oncology to boost the hematopoiesis. This part was not successful, but the side effects are very interesting. So now I come to a second conclusion, which is interleukin-3 obviously lowers cholesterol in humans, which means that our positive correlation of interleukin-3 levels with cholesterol levels could be a compensatory mechanism. Now we have 2 new questions. How does interleukin-3 lower cholesterol? And is IL-3 actually arteroprotective? To answer these questions, we utilized animal models, in vitro studies of both human and murine cells. And these questions will be answered in 1 hour by my boss, Dr. Swirsky, in his talk. With this, I want to thank our great team and all our collaborators around the world, and I'm open to some questions.
Thank you very much. Is there any questions from the audience? Yeah, thinking of all of your human data, did you notice if there was any correlation to IL-3 expression on any confounders? Was it higher in men or women?
So we checked for it. For example, our BioMe study reflected very balance between men, women, and there was no significant difference, no sex-specific effect. And also in our other studies, we couldn't find anything.
Okay, let's thank Dr. Ratner.
Okay, all right. Moving on, right on time. Our next speaker is Dr. Prabhat Kaur. She is currently a postdoctoral fellow in Dr. Hadri Lahoria Lab in the Department of Pharmacological Sciences. She's a recipient of a prestigious national level doctoral fellowship under the Department of Science and Technology, Innovation and Science Pursued for Inspired Research, which is an acronym for DST Inspire. As a result of her tremendous academic achievement during her master's years. She completed a doctoral of philosophy in life sciences from Guru Nanak Dev University, Amritsar in India. She joined Dr. Hadri Lab in April of 2024 with a very unique focus on developing novel therapy for vascular proliferative diseases, just such as pulmonary fibrosis and a very important pulmonary arterial disease. Join me in welcoming Dr. Kaur to the podium.
Hi, thank you so much for inviting me. I'm Prabjot Kaur, postdoc fellow in Dr. Hetri's lab, and today I'm discussing my research work on targeting IL-6 STAT3 STAT4 signaling restores FOXP3 expression in pulmonary arterial endothelium, and it reveals novel biomarkers in PAH. PAH is pulmonary arterial hypertension, which is group 1 disease, which is rare and deadly cardiopulmonary disease, and in PH, IL-6 is a central driver uh, uh, which leads to right ventricle dysfunction, increased pulmonary vascular resistance, and poor prognosis. However, a specific downstream mechanism by which IL-6 drives PH is still not explored that much. Right now, recently there was one clinical trial, Transform UK, which have targeted a monoclonal antibody to block IL-6 receptor. Although it was safe and well tolerated, but it failed to meet the clinical endpoints. And recently, nowadays, there is one research group working on Satisfy JP trial in Japan, and they are focusing on biomarker guided therapy. With this background, we investigated the therapeutic impact of direct IL-6 neutralization and its regulation of novel epigenetic signaling axis. And for that, sorry. Thank you. So for that, we have used MCT-induced pH model in rats, and we have seen that direct IL-6 neutralization, it attenuates pulmonary vascular remodeling, and we have seen significant reduction in the pulmonary arterial pressure and also right ventricle systolic pressure in comparison to vehicle-treated group. And from the cardiac MRI data and as well as from the morphometric parameters, we have identified that IL-6 neutralization, it leads to significant reduction in fibrotic markers as well as hypertrophic markers, and also it 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 is safe for it is safe for BMPR2 induction, which is vital for vascular health. And the similar model we have mimicked for the mice as well. And here we have used Sugen hypoxia induced model. And there also we have seen that IL-6 neutralization, it reduces RV dysfunction. And we have seen efficient, significant effects in the RVEF as well as the TAPSI score. And also the right ventricle pressures were reduced significantly, as well as the medial wall thickness, as well as alpha SMA marker, as well as different fibrotic markers and hypertrophy markers were evaluated, and they showed safe side. Then RNA sequencing data from the lungs of Sugen hypoxia mice, they showed that FOXP3 is a key transcriptional target, and also along with that we have find out different transcription factor, that is STAT3, STAT4, and we have found that there is STAT4 binding sites on the FOXP3 genes, therefore they show a connecting regulatory link. So for that, so we have evaluated, we moved to IL-6 as well as FOXP3 axis, and we have seen that there is a significant reduction in the FOXP3 expression in the experimental pH models as well as in the human pH models. And when we checked in the same set of pH rodent model and humans, we have seen that there is a inverse association of FOXP3 as well as IL-6 expression. And we wanted to know by which mechanism it is affecting or silencing FOXP3. So we came across one of the mechanism that is it is through STAT3 as well as STAT4 interaction. For that we have done IL-6 neutralization, and we have seen that there is STAT3 and STAT4 are directly interacting, whereas with the use of STAT3 inhibitor as well as IL-6 neutralization, there is a disruption in this interaction. Also, on the FOXP3 promoter, there is a increased STAT4 occupancy in the diseased model, whereas when we used IL-6 neutralization, there is a significant reduction. Then another mechanism which we explored is through DNMT1 mediated promoter methylation, because we have seen that there is a higher DNA methylation in the diseased pH cells, but when we treated with the IL-6 neutralization, then we have seen there is a significant reduction in the methylation levels, and also we found out that on BMPR2 gene there is FOXP3 binding sites, and then we observed downstream signaling, and there is improvement in downstream signaling using IL-6 nutrition through the BMPR2 and phosphosmad axis. So from here we can conclude that IL-6 drives pulmonary hypertension through two mechanisms, that is STAT3 and STAT4, as well as through DNMT1 dependent epigenetic repression of FOXP3, therefore linking chronic inflammation of BMPR2 dysfunction and pulmonary vascular remodeling. Whereas IL-6 neutralization, it reverses this whole pathogenic condition, and FOXP3, it therefore emerges as a mechanistic biomarker, and also it's a potential tool for precision stratification of patient, and may be useful in the ongoing clinical trials as a potential marker. Thank you so much.
You.
Do we have any questions for Dr. Carr? I have a question. You know, from a clinical standpoint, there's a medication called sotatercept that basically works in the pathway of the BMP2 receptor, BMP2 pathway. Where do you see this IL-6 sort of coming into the room? Do you think the goal is ultimately to be able to develop a pharmacotherapy to target, this pathway to be able to improve clinical outcomes in pulmonary arterial hypertension?
Yeah, sure. I mean, there are different inhibitors which are currently in trials for this one. So maybe in future we will be able to evaluate more pathways for targeting this particular axis. Yeah, thank you so much.
Thank you. All right. If we can just stretch our legs for about 3 minutes. Our next speaker is scheduled to would be at 2:15. So I know it's been a long, amazing talk so far. So just stretch your leg, get some hydration, and let's come back in the next 3 minutes. I didn't raise my
Estimated that there's up to 200,000 patients like this in the United States. They all have class 3 or 4 angina, but they live a long time. Interestingly, they have a good prognosis in terms of relatively low rates of death or MI, but they often can't walk across a room. So one of the potential options for these patients, because there's no drugs that we found that provide much benefit, beyond the 4 anti-anginal drugs, is this coronary sinus reducer. And this is an hourglass-shaped device that you put in the cardiac sinus, the coronary sinus, as it enters the great cardiac vein in the anterior wall of the heart. And it puts a pressure gradient across this hourglass, and it increases backflow to redistribute blood flow from the subepicardium to the subendocardium. And there was a positive, randomized, small, sham-controlled trial that was published in the New England Journal about a decade ago. And for a number of years now, we've been running the pivotal approval trial called CASIRA-2. And this is a 380-patient, double-blind, randomized, sham-controlled trial in patients with, again, obstructive coronary disease with no revascularization options and class 3 to 4 angina, with a dual co-primary endpoints of improvement in quality of life, that is angina relief, and improved exercise tolerance. And we've randomized approximately 200 of these patients, and randomization is really picking up. So we're very excited about this trial being done. Now, if we look at patients who present with acute myocardial infarction, everybody knows the very exciting results that came out about a year ago from the DanGer Shock trial, the first positive trial in cardiogenic shock. These are the worst prognosis patients we see that have about a 50% 30-day mortality. We brought that down from about 80% by being able to do PCI in cardiogenic shock. But with AMI, particularly STEMI cardiogenic shock, we've been stuck for about a decade at about a 50% mortality. So the DanGer Shock trial, which took 10 years to complete in Germany and Denmark, showed that the use of a microaxial flow pump in these patients can reduce mortality from about at 6 months, from 58% to 45%. These results persisted through 7-year follow-up. Number needed to treat was about 8 patients to save 1 life. The downside was that there were a lot of complications. Okay, not only are there vascular and bleeding complications, there's hemolysis, there's limb ischemia, there's a lot more dialysis, there was sepsis, there was stroke. So this was really a concern, although the combination of mortality, of course, the most important endpoint, was able to get a class 2A recommendation for this in acute MI cardiogenic shock. So one question is if we institute so-called best practices of how to put Impella, how to wean it, how to assess it hemodynamically, when to take it out, et cetera, and there's lots of tips and tricks, can we reduce this adverse complication rate? So here's the one non-randomized trial that I'll show you that we're excited about, on which I'm the study chair, called OASIS AMI cardiogenic shock, where we're basically enrolling a similar 350 patients. DanGer Shock was 305 patients, or 350 as well. With AMI cardiogenic shock, very similar inclusion criteria, but we've instituted 31 best practices with Impella to try to decrease all these adverse complications. And the primary endpoint here is a composite major adverse events endpoint compared with patient-level data from DanGer Shock using a propensity-weighted analysis. And this is now actively enrolling. Looking further beyond in patients with acute myocardial infarction, one of the earlier trials we had done was looking at, Bob mentioned bivalirudin. And we did a series of trials with bivalirudin, which culminated in BRIGHT 4, which was published in The Lancet a couple of years ago. And that actually demonstrated reduced mortality and reduced major bleeding in patients undergoing a radial standard PCI, STEMI primary PCI. And this led to the most recent 2025 US guidelines giving bivalirudin a class 1 guideline for use in STEMI compared to heparin. But the question is, what about other patient settings? That's STEMI. So we're now running the BRIGHT HBR trial, which is 5,270 patients with non-ST segment elevation acute coronary syndromes or recent stabilized STEMI who are at high bleeding risk, and randomizing these patients to bivalirudin versus unfractionated heparin with a primary endpoint of net adverse clinical events, that is the combination of death, ischemic adverse outcomes, and bleeding. And this trial has enrolled about 800 patients so far. Looking even more ambitiously is the FAVOR 5 AMI trial, and this is in patients with STEMI and multivessel disease, which is about half of our patients, and there's been a lot of interest and questions as to how we choose not the STEMI lesion, but the non-STEMI lesions. How do we revascularize them? Right now, we just revascularize those that have an angiographic diameter stenosis of 70% or greater. Sometimes we use physiology to help us guide that assessment, but we're looking for vulnerable plaques. Okay, Dr. Fuster and my favorite topic. Okay, that's really where the benefit has been shown to be able to reduce myocardial infarction by treating those 70% or greater stenoses by about 50%. But we're leaving a lot of them behind. And so this is a large-scale randomized trial, 5,000 patients, where the control arm is basically that standard treatment. And in the treatment arm, we're using a combination of micro-QFR, which is a physiology-based system based on the angiogram to be able to assess significant physiologic lesions. But perhaps more exciting, we're using a way to assess vulnerable plaque called radial wall strain, which basically looks at lesion compliance and has been shown to be very accurate in predicting intravascular imaging associated vulnerable plaques. So this is a 5,000 patient randomized trial to see if we can reduce death and myocardial infarction. So now let's shift away from coronary intervention to other areas, and let's talk about hypertension. Okay, hypertension in interventional cardiology, of course, is renal denervation. And renal denervation is being increasingly used as a treatment for refractory hypertension, although it's only got modest benefits. And right now there are two systems that are approved. One is an ultrasound balloon-based approach, and the other is radiofrequency point-type energy. So a third type approach is alcohol-based renal denervation, and it's a very simple catheter that has these three little needles that come out into the adventitia, and you can inject ethanol. And that actually produces, compared to some of the other techniques, a very circumferential neurolysis, which can lead to, again, treatment of hypertension. There have been several trials run with this. There are on-med and off-med trials. The on-med trial was positive, but they ran a small off-med trial, which was actually negative. And so actually it was positive, but it wasn't positive enough. So we're actually now running the confirmatory trial in a larger number of patients, which is 202 patients with uncontrolled hypertension off meds. They're on standard, they're on 0 to 2 meds. Now we take them off meds for 4 weeks, and as long as they've got still, blood pressures in about 150 to 180 millimeter range, we then randomize in a sham-controlled double-blind trial to alcohol-based renal denervation versus a sham procedure with a primary endpoint of reduction in blood pressure by ambulatory measuring it at 8 weeks. And then one nice advantage of this is it causes much less pain than patients who get other forms of renal denervation, which for those of you who have done it are very well familiar with. So this is an important trial. Now if we go to patients with heart failure and cardiomyopathy, first you've got patients who have functional mitral regurgitation, a topic close to my heart after the COAPT trial. And of course, about 80 to 90% of functional mitral regurgitation that develops in patients with left ventricular dysfunction is ventricular mitral regurgitation, either on the basis of ischemic cardiomyopathy or idiopathic or other causes of dilated cardiomyopathy. But an important 10 to 15% of this is atrial functional MR, where actually the ventricle is normal. In fact, a lot of these patients have heart failure with preserved ejection fraction, and they have a primary dilated annulus, either due to an atrial cardiomyopathy or long-standing atrial fibrillation flutter. And here you've got a very different anatomy, and we don't know that mitral transcatheter edge-to-edge repair works. We know it works in these, and it can reduce mortality and heart failure and improve quality of life from the COAPT trial, but we don't know anything about treatment in atrial FMR. So we're running a trial called STAR, which is a 400-patient trial with severe atrial functional mitral regurgitation and preserved left ventricular function, randomizing these patients to mitral transcatheter edge-to-edge repair versus medical therapy alone, with a primary endpoint of death and heart failure. Now, if we go to valves, again, there's only so many patients we can treat with transcatheter edge-to-edge repair. It's a great procedure because it's very safe, it's effective, but it doesn't eliminate mitral regurgitation. And of course, there are now 2 transcatheter mitral valves that have been approved in the United States, one of which is from a transapical approach, which is a mini surgical procedure, but we have now one that was approved about 4 months ago for transeptal use. So the problems with that is that about 90% of the patients are not eligible for it, and you've got a high incidence of left ventricular outflow tract obstruction because of the large profile of the devices. You've got paravalvular leaks, hemolysis, and other issues. So this is a valve that I'm involved in, which is called High Life. This is the Clarity valve. It's a very unique design. It actually catches the anterior mitral leaflet when you implant it, so you actually have no left ventricular outflow tract obstruction. And instead of 10% of the patients have been eligible, because of that, about 60% of patients have been eligible for treatment of these valves. So we are running an FDA approval trial, which is actually about to start. It's going to start within the next 2 weeks, on which we're taking patients with severe secondary mitral regurgitation, very similar COAPT criteria, but not appropriate for M-TEER and not appropriate for primary surgical operation. And the single-arm study will be implanting the valve and using the COAPT population as a control group. And then finally, or almost finally, I'll go to heart failure. So we've been very excited about the concept for patients with heart failure without primary valvular disease to look at interatrial shunt technology. And a lot of companies have developed a small shunt, anywhere from about 5 to 8 millimeters in diameter, that you can place in the fossa ovalis, and it basically creates an auto-regulatory mechanism such that as the left atrial pressure rises, you increase blood flow from the left atrium to the right atrium, and that decreases congestion, and it improves symptomatology, and it allows actually better cardiac output, and may also reduce mortality. And so here you can see multiple different devices. Most of these are intraatrial septal devices. One of them is actually a coronary sinus to left atrium device. 3 of them are permanent implants, and 3 of them actually leave nothing behind. They just core out a small amount of tissue. So we ran a trial called the RELIEVE-HF trial, which was recently presented and published. And overall, it was a negative trial. But we saw markedly disparate outcomes in patients with reduced ejection fraction, where there was a marked improvement in outcomes, about a 45% benefit, and in patients with heart failure with preserved ejection fraction, those patients actually have much stiffer ventricles that do less well in tolerating blood flow redistribution from the left to the right heart, and they actually had increased mortality and increased outcomes. So of course, though, this was with one particular shunt. This is the V-Wave Ventura shunt, and this needs to be replicated. So in one of those trials that have not yet been announced, there will be a study coming out to replicate this with a Bayesian fashion. But in the meantime, we're leading the ALAY-HFrEF trial. And this is with a shunt device that uses radio frequency energy to just core out a small 7 millimeter diameter hole and then remove the tissue. So you can actually get an atrial tissue biopsy, which is interesting. And we're basically taking patients with core lab proven left ventricular ejection fractions less than 40% who are symptomatic despite all best guideline directed medical therapies, and randomizing them in a double-blind sham controlled randomized trial to either an intraatrial shunt versus control. And this is enrolling quite quickly. And then very lastly, the patients that I think have the worst prognosis with heart failure are those in whom pulmonary hypertension develop. And when you have particularly what's called combined pre- and post-capillary pulmonary hypertension, PH drugs don't, sorry, it's got this on it, auto-advance. PH drugs don't work for those patients. But one thing that might work is pulmonary artery denervation, because there's sympathetic excess in all of these patients. This is a catheter called the Pulnovo Enhancer catheter, which is a multipolar catheter, which is quite an easy procedure to advance in the pulmonary artery and denervate the pulmonary artery and decrease sympathetic outflow. And after very positive pilot randomized trials, we're now running the pivotal US and European trial called Pulse LHD, which is a sham-controlled double-blind randomized trial of PADN for combined pre- and post-capillary pulmonary hypertension associated with left heart failure. And this is a 500-patient randomized trial at 125 centers, which has recently begun. So I'll just close with this slide. Linus Pauling, why am I closing with a chemist? Quote from a chemist said many years ago that the best way to have a good idea is to have lots of ideas. And I hope I've showed you that if anything, cardiologists have lots of very interesting good ideas, really fertile areas of research that are ongoing. And if anybody would be interested in being involved with any of these projects, please reach out to me, Dr. Bott, Dr. Fuster, or any of the other key Mount Sinai faculty. Thanks very much.
All right, we have
Room for one question for Dr. Shell from the audience. I'm not going to ask a question, just rather, I could ask a lot of questions, this is brilliant, but I just have to make it out that if it's not only people in training here, I mean, that was really masterful. And as an individual, you're actually doing and leading more research than most departments of medicine, most sections of cardiology, most academic research organizations in total. I was reflecting on your talk, and it's really amazing. So thank you for your contributions to the field of not even just interventional cardiology anymore, but cardiology, cardiovascular medicine. Thank you for what you do for Mount Sinai Freestyle Heart Hospital's H Index. Actually, I contribute any other faculty member. It helps with our ranking, which is it's actually probably deep and not Sinai, but a large proportion of that are your high impact publications. So thank you for all that. I'll turn to Dr. Harrington if you've got any question.
No, I just think there are a couple things. One of which is that I share Deepak's enthusiasm for what you're doing. And secondly, I give you a lot of credit because you've always been one of the people who've said, well, we're going to test it. And because we just don't know if we don't test it. And so kudos to you for doing it. It says a lot.
Well, thank you both. Now I'm thoroughly embarrassed, but I really appreciate the kind words. Thank you.
Okay, thank you. My name's Abby. I'm a PhD student in the Cardiovascular Research Institute, and it's my honor to present Dr. Phil Swirsky. Dr. Swirsky earned his PhD from McMaster University in Canada and completed his postdoctoral studies at Brigham and Women's Hospital. He was professor at Harvard Medical School and Massachusetts General Hospital before joining Mount Sinai in 2021 as the director of the Cardiovascular Research Institute. Dr. Swirsky's research centers on innate immunity and inflammation in cardiovascular disease, with specific emphasis on lifestyle factors such as sleep, diet, stress as critical modulators of cardiovascular health and hematopoiesis. More recently, Dr. Swirsky's lab focuses on brain-body communication in cardiovascular disease, including neural interpretation and control of cardiac damage and hematopoiesis. So please join me in welcoming Dr. Swirsky.
Thank you, Abby. So I invited myself to give this talk because I really wanted to tell you a story that we're very excited about. You already heard the first part of it when my postdoc, Thomas Ratner, was giving it. And so I just thought this is just a good time to tell this story. And so I will tell you only one story. The lab is very interested in all sorts of things. We're very much interested in understanding the relationship between the heart and the brain, and incorporated a lot of neuroscience tools to really better understand how the nervous system, the metabolic system, the circulatory systems talk to each other. But today I will tell you a story that is actually somehow traditional in the sense that it sort of harkens back to some of my earlier interests in inflammation and cardiovascular disease, but it is unexpected and surprising. So what you saw when Thomas spoke was really figure one. And figure one is a figure that establishes across genomic, transcriptomic, and proteomic pipelines that interleukin-3, which is discovered after interleukin-2 and before interleukin-4, actually was discovered earlier, but it was named around this time, associates with cardiovascular disease. Okay, let's just keep it at that. Just remember, it associates, it arises as cardiovascular disease rises. It arises as cholesterol levels rise. And so that really is the starting point here. And I'm just going to sort of give you a series of questions that we may want to ask about what interleukin-3 might be doing. The first thing you could say, well, it rises with disease. It could just be a marker, and Thomas alluded to this. It could be CRP. It may not be particularly interesting functionally. If it modulates disease, by how much, and I think this is the key point, in what direction? I would hazard to guess, especially if you were not paying attention to anything that Thomas already said, that if we were to do a little bit of a survey here, and I told you that this molecule rises with cardiovascular disease, number one, and two, it's a hematopoietic factor. It acts on the bone marrow to generate immune cells. I would hazard to guess, you would say it has to be pro-disease. It is rising and it's causing disease. That's how we would think about IL-1. That's what we would think about TNF. But then I will remind you that we also have things like IL-10. You know what happens to IL-10? It rises with disease. But you know what it does? It acts against it. So it is important that we ask this question. And then, of course, I would say we need to understand the underlying disease. We've heard about clinical trials and the amazing clinical trials that have been done. I would suggest that many of the reasons why many clinical trials fail is because we don't understand the underlying disease. And this is where mouse models become particularly important. So what we had done as a start was to essentially go back to the mouse and simply generate IL-3 knockout that is atherosclerosis susceptible. There's different ways that we can look at atherosclerosis, and this is what we found. So these are ApoE mice, one of the two main mouse models for atherosclerosis, and in the absence of interleukin-3, what we find were bigger lesions. Despite the fact that this is a hematopoietic factor, we don't see any changes in blood leukocytes or bone marrow leukocytes. And when we saw this, and we saw this a long time ago, we said, what is going on? This does not make any sense at all. We thought we're going to have a very simple paper that IL-3 is promoting disease. It's in the bone marrow. It's going to be extramedullary hematopoiesis. We're going to send it to, I don't want to name a journal, just so I don't want to insult a journal, but we're going to wrap the story up and move ahead with it. But here was a conundrum and a question that we really were struggling to answer. And this particular study that, out of the several studies that we published about IL-3, offered us a clue as to what may be happening. This is a study that we published in Nature. This was actually, I think it was one of the last studies that Cameron McAlpine, who is in the audience, who is a postdoc of mine, and he came here, now is as an associate professor and runs a very exciting program, published while still being a postdoc in my lab. This was a study using mouse models of Alzheimer's disease, as well as human Alzheimer's disease, showing that interleukin-3 is protective in Alzheimer's disease. And we heard Dr. Fuster speak about these mechanisms that really connect the two diseases. And that's why I'm bringing this study to your attention, because it will help us understand what is going on about interleukin-3 and atherosclerosis. So then we sort of moved back and said, well, let's measure a few key factors that are perhaps going to help us understand what the role of interleukin-3 may be. So the first thing that we did, just still relying on the mouse, we'll get to more human data in just a moment, we find that if you feed an ApoE mouse high cholesterol diet, interleukin-3 levels rise. So what we find is consistent in the mouse and the humans, more interleukin-3 as we feed a diet high in fat and cholesterol. If we simply take an interleukin-3 mouse out of the box, do nothing to it, and measure cholesterol, what we find, it has heightened levels of cholesterol. It has more LDL. And if we deliver recombinant interleukin-3 to a mouse, what we find is it lowers cholesterol, mostly LDL. And before you look at this and go, that doesn't really seem to be all that much, may I remind you that if you do the exact same experiment with statins in the mouse, you lower cholesterol by exactly the same amount, except it takes 4 times longer to do it. So this is something that limits cholesterol as well as a statin in the mouse, but it happens 3 to 4 times faster. So at this point, what we have is evidence that interleukin-3 is protecting against atherosclerosis, and it might be doing so by limiting cholesterol, which really now forces us to ask the question, what is the underlying mechanism? And if you want to know what an underlying mechanism is, one of the things you have to ask yourself is, what is the receptor upon which a particular molecule that you're studying, especially if that molecule is secreted, is acting on? So here we turned our attention to human data, and working with Sikander Hayat, who is going to be telling us about AI and everything that exciting that's happening at AI, and queried millions of human cells, both using bulk RNA-seq and single-cell RNA-seq, to ask where in the human body interleukin receptor alpha, the specific receptor for this cytokine, is located. And this is what we find. So the first thing you'll find is that it's not expressed everywhere, but it's not also expressed as just in one place. But we can look at the various tissues in which it is expressed. And as we essentially evaluate the amount of IL-3, after the lung, the adipose tissue is the second tissue where we find interleukin receptor alpha expressing cells. And if we zoom in on that tissue, we find that it's expressed in a number of different subsets. And here I'm putting my finger on the scale a little bit for reasons you'll see in just a second, because when we actually look at the myeloid component, what we find is that myeloid cells express interleukin-3 alpha, not all of them. The neutrophils there on the very left, they do not express IL-3RA. Plasmacytoid dendritic cells on the very right at the bottom express interleukin-3RA very highly, but there are very, very few of them. The macrophages in the adipose tissues are in a Goldilocks zone, where there is a large number of these macrophages expressing IL-3RA, and they express it at high levels. So you really, it's a cell that stands out. And the reason I'm pointing to this, keeping in mind that we see exactly the same thing in mouse. This is taken from ImGen, which, I just want to sort of emphasize that mouse models have their problems, but they are actually pretty good in some cases. And in this case, I would argue is one example at telling us something about potential human biology, if you understand the caveats. So in the mouse, macrophages, and particularly macrophages residing in tissues with a lot of fat, including the epididymis, which I think is quite interesting, express the interleukin RA. So does that mean that macrophages are responsible for the phenotype that I've shown you, the phenotype being lowering cholesterol? So what we can do here is essentially go way back to some very classic tools and first utilize clodronate liposomes. This is one way that's been studied for a long time as a way to essentially delete macrophages in a tissue. And if we simply take macrophages in culture, or actually this is in vivo rather, inject recombinant IL-3, we see the sort of lowering of cholesterol. If we deplete macrophages, we fail to see this. We no longer limit cholesterol decline in response to IL-3 when we delete macrophages. And there's a really profound and dramatic phenotype pertaining to the accumulation of neutral lipids in both the adipose tissue and the liver, and I'll return to this in just a moment. Of course, that is a crude, old way of doing this. What we can do is something a little bit better. What we can do is we can specifically delete the specific interleukin-3 receptor only from macrophages. And this is why I put the finger on that balance earlier, and I didn't focus on the vascular cells, because when we do this, we exactly phenocopy what we find in the absence of interleukin-3. What we find is atherosclerotic lesions get bigger to the same extent. So it seems that we have this circuit. What I think is absolutely remarkable about this is not biology that happens in the vessel wall. Interleukin-3 is produced in the vessel wall, but it acts on macrophages in adipose tissue and also in the liver. So this is a systemic circuit that really teaches us that atherosclerosis may be not just a local disease, and really is something that we think about quite a bit. So now let me just get deeper into a mechanism. What is going on here? And one of the ways you can do this is in vitro. And here you could look at what we did now and you go, wow, that's not very sophisticated, because what we did is we took bone marrow derived cells, we made them into macrophages in vitro, we added interleukin-3 and we did bulk RNA sequencing, and we looked specifically at cholesterol handling genes. And if you're a macrophage aficionado, you would say, whoa, whoa, whoa. Why don't you just study adipocyte macrophages? Why look at the bone marrow? There's two reasons. One is practical, we get a lot of cells. The other is that we're really asking a very fundamental question. Whatever it is that we find, if we find it, if it occurs in an artificially generated macrophage from the bone marrow, it speaks to a core process, a core identity of a macrophage that can be preserved even if it is not imbued with the tissue circuits that imbue a macrophage for specific functions in the tissues that they reside. So this is what I'm going to show you. This is a sort of a cell, and what we're going to see as I start to animate this, you're going to see two squares. The first one is going to be either red or blue, and that tells you whether in response to interleukin-3 that gene is up, red, down, blue. And then you're going to see another square that's sort of green or white, and that tells you that if it's green, it's statistically significant. Okay? So the first thing we do is we look at IL-3 itself. We've added IL-3 onto this macrophage, and what we find is that it doesn't really change the expression of interleukin-3 receptor alpha, but it does have some effect on STAT5. Interleukin-3 acts via STAT5. And there are some other things that you might find here of interest to you. Things start to get interesting once we look into the cholesterol processing. What we find is LPL increases, and the most dramatically increased gene is LDL receptor, and then after that, the MSR. So this tells us that interleukin-3 tells the macrophage to start importing neutral LDL, just LDL itself, as well as through these scavenger receptors, oxidatively modulated LDL. And if that's the end of the story, you would say, whoa, whoa, whoa. You are telling me that these macrophages are going to become foam cell because they're just bringing in, and there's a lot of information, a lot of things we know about foam cell generation in the atherosclerotic lesions. But something much more sophisticated is going on. As we go across, what we find is that the second gene that is upregulated, I don't like to use the word like upregulated, augmented in response to interleukin-3 is ABCG1 on the transcription level. And then there are something else is happening. We see the increased expression of a number of genes involved in oxidative phosphorylation. So the macrophage is essentially increasing its metabolism, perhaps to start processing LDL. And then we also see a very robust increase in the cholesterol synthesis pathway. And we don't understand why that may be, but of course the cholesterol synthesis pathway is at the root of many hormones that are being produced, potentially telling us something about the regulation of the cell. So what we're doing here, uniquely in this macrophage, we have this LDL to HDL IL-3 driven macrophage processing. And we're kind of making a macrophage into a hepatocyte of sorts, although not really, and it's very much an on-demand mechanism related to IL-3. In case you say, well, this is all in the mouse, this is all in an in vitro system utilizing interleukin-3, when we look at some human data sets from adipose tissue in the liver, this is from Muir-Hacohen's work, where they looked at what happens across tissues. Actually, this is not from Muir-Hacohen's work. What we find is something very similar. Interleukin-3 Ra-positive macrophages have this machinery that's really expressed, related to cholesterol metabolism, higher than anything you'll see in an interleukin receptor negative macrophage. And so let's now, I mean, that's computational. We spoke about the importance of computation, but we need to do some empirical experiments to understand whether all of these computational things that we find actually have basis in fact. So one of the things we had done, this is with Nikki and with Lee Gadicki sitting here in the audience, is done seahorse. And what we find, consistent with the oxidative phosphorylation that we find, is that we have sort of an increase in the basal respiration and maximal respiration in these macrophages. And then if we do experiments in vitro where we again differentiate these macrophages to bone marrow cells to macrophages and then add LDL and add IL-3, we find that LDL levels decline in supernatants, and this is dependent on endocytosis. So the macrophages are sopping out LDL out of the supernatants. Then we switch the supernatant, add a little bit of HDL as an acceptor, and what we find is that now you have more HDL in the supernatant. So they're eating the LDL, processing it, and spewing out the HDL. And there's this difference. Something that's quite interesting about, this is using spatial transcriptomics, human spatial transcriptomics. I'll just put this out here for just a second. This is also working with Sikander and his PhD student, Leon Frommer. What we find is that these IL-3 RA positive macrophages, adipose tissue, reside very closely to the endothelium. So they're strategically positioned to sense cholesterol levels and potentially then donate it to adipocyte for storage. And so if we now deliver interleukin-3 in an osmotic mini pump, what we essentially see is we see the stop of the growth of atherosclerotic lesions. And this really got us to thinking about developing drugs, which we have proof of principle drugs, where we find that we can actually lower LDL cholesterol very dramatically within only 5 days of delivery. And what happens to this cholesterol? Well, what we find is that it comes out in the poop. These mice do not poop more, they just poop more fatty poop. And I have 30 seconds here, and we can really stop atherosclerosis. So what we find is that we think that IL-3 really converts these macrophages strategically located in tissues that are rich in fat into cholesterol processing plants, if you will, for this on-demand mechanism that we think we're excited about. And I will just finish with one final thought, is that while this is a cholesterol-lowering mechanism, and we know that cholesterol lowering is a very sort of difficult space because we have all of these drugs for cholesterol lowering, but it's about making macrophages burn harder and metabolizing, and there's all of these additional effects that we can start seeing. So the cholesterol is only the beginning. And so this is why we're excited about this project. And this is why I thank myself for inviting myself to give this talk. Okay, so thank you very much. So just before, so Thomas gave you that sort of figure 1. I gave you figure 2, 3, and 4. And then Alexander Lunig, who is the first author on this with Thomas, was really sort of the driving person of this. Many others in the lab and in other labs have helped. So these are the sort of the authors of the paper, of the manuscript as it stands. Thank you for your attention.
I know we're in it, but I will ask one question here. First of all, congratulations. This seems really revolutionary, like a breakthrough to me. And it's perfect to see so many different folks from CVRI involved in your leadership. So congratulations on that. The mechanism, I think, is really quite scientifically provocative. What do you think would be the effect if a patient, taking this to patients and assuming this for in trials or in actual clinical use, is receiving, say, GLP-1 agonist or dual incretin like tirzepatide, reducing the amount of adipose tissue there, in the belly and the parting space all over. So what is adipose tissue? Would this mechanism be still complementary to that sort of approach, or do you think there'd be some subtracting?
I love this question. Of course, to GLP, we can also ask about statins. And to the extent that the mechanism really acts on a very distinct pathway, orthogonal, let's say, to cholesterol synthesis or to anything that's sort of blood sugar, what the GLP does, there is, I would say, an intriguing idea that it could be additive or synergistic. And of course, these are experiments that are underway. But I love this idea as a way to just really focus on metabolism. Yeah.
Fantastic. Let's focus on the volume for a moment. Cheap and obesity have stimulated the volume and they are pro-inflammatory in the vessel wall. What do you think happens?
This is a fantastic question. So it's a question that I can probably take 30 minutes to answer, but let me just be very succinct. In the context that we're looking here, we see no difference on hematopoiesis, which was actually surprising. It's that what moment, because if you add interleukin-3, you're going to generate leukocytes. And if you add a lot of interleukin-3, you're going to generate them. So it might be a threshold effect. It might be a sort of a second signal, third signal effect. And I will say one thing also is that interleukin-3, Thomas showed these data, it was delivered to humans in the 1990s as a way to refresh the bone marrow in cancer patients. We forgot about these studies because they didn't work. And maybe because they didn't work, that's actually the advantage for us now. There was an offhanded, it reduces cholesterol. So it's something about interleukin-3 that might require accessory sort of signals. And so the threshold for activating the bone marrow is much, much higher than, for example, its brethren, if you will, GM-CSF, which we find has different biology that is more sensitive to the production of immune cells. So it's a great question and an important one as we navigate the possibility of translating and this particular discovery. Yes.
Excellent story. They love PVHDL. The only question is, the only thing that doesn't fit in the story is if you increase the internalization of cholesterol in the repeated study, why there is an increase in the synthesis of cholesterol?
Yes, this is super interesting, right? And so what I haven't shown you is I've collapsed the time here, right? So I've added IL-3, we look and then we measure. We don't actually yet know how all these pathways are connected over time. And so you can imagine that the first thing that happens is the export of cholesterol via ABCG1, ABCA1 in response to interleukin-3. That sort of, the cell senses a dearth of it and perhaps stimulates the production. You could imagine that there's something else going on where there is an influx. There is this oxidative phosphorylation, that sort of metabolism, and you can connect the dots in time in different ways. The other thing is that perhaps these genes that are in the cholesterol synthesis pathway are genes that are going to endow the macrophage with the capacity to communicate with adipocytes and with hepatocytes via byproducts. Because when we all remember, I think we're going to hear from Tim Kenny very soon, who really studies and thinks about metabolism a lot. We all remember our Boehringer Ingelheim biochemical pathways, and the cholesterol synthesis sort of sits in the center of it. So it is what it is. We see it in a mouse, we see it in a human. So I would say it's a question of intrigue, and I'm glad that you caught that as something that really requires further investigation. Thank you so much. Okay, thank you.
It is with great pleasure that I'm introducing our next speaker, Dr. Annapurna Kini. Dr. Kini is a world-renowned leader in the field of interventional and structural cardiology. She currently serves as the director of the Cardiac Catheterization Laboratory at the Mount Sinai Hospital and is a professor of medicine and cardiology. She is widely recognized for her exceptional technical mastery in dealing with complex coronary lesions, while at the same time achieving some of the highest safety rates in the nation. She is a prolific researcher leading multiple landmark trials and an innovator constantly using artificial intelligence to improve patient care. Please join me in welcoming Dr. Kini.
Good afternoon, everybody, and will be a complete, I would say, a change of a topic. And the interventional cardiologist will be talking on the artificial intelligence and a little bit of translational research after Philip gave us a beautiful talk. So first we'll talk on what we've been doing in the cath lab. So whatever 5 points that I'm talking will be what we are doing right now in the cath lab using artificial intelligence. So first we'll go to education. It's very important that being in a teaching institution like this, what we are doing to our next generation. So you see that over the last 25 years, we have had several symposiums that we've been teaching both the interventional cardiologists and the fellows. For the 15 years, we've been doing education, which is live, being broadcasted all around the world. So initially was only, you would see the coronary, but subsequently we have added more. Then if you see the number of cases we have done, complex coronary, we just celebrated the 200th case. Several cases have been done. Now the question comes is, can we incorporate AI into these teaching modules that we have? So as you see here, yes, we have incorporated AI, which is very easy. You can ask AI generated case summary for live as well as archived cases. If you have joined it late, you can subsequently ask, just give me a quick summary. You can have a chat bot with the AI, take a quiz. And at the end, what you can do is you can say click and navigate same timestamp as we're going through this videos, explain this moment because you joined late. It will immediately tell you what is happening. So these are the things that are available and you can see them on the website. We have created several educational apps since September 2017, if you see, all over that we have done. And the latest one that we came out was hemodynamic, and I would urge all the cardiology fellows, medical students to download. All these educational apps are available on cardiologyapps.com. So it's important that you understand that when you come to the cath lab, what are the hemodynamics that we use? And this particular poster actually has been selected as one of the finalists right now outside. So we have Mary Glenn who will be probably presenting it. So like I mentioned, these are free, available worldwide. Please go ahead and download them from cardiologyapps.com. Then comes, so you have seen this, all the live cases, all the apps, which is like a textbook, okay, that is available. The question comes, can AI help us in this current era, instead of going through every page, watching all those live cases, which we thought a full-time person can take between 3 to 4 months to understand how much education is up there. So we can use specially trained LLMs and various algorithms and come to understanding of what is out there on our website. Care coordination, which I presented actually last year, which is very dear to interventional cardiologists, is STEMI. So if you see here, when there is a STEMI, there is alert to the interventional cardiologist from the ED person, and we'll understand through a few important things about the patient. But more important is we are able to track the patient when they're being transported from our sister hospitals coming to the cath lab. We are not on the phone. The pagers are completely out. So we have several publications related to this and presented in various international and national meetings. Right now, Derek Pineda will be going to Australia talking about this thing. What's the future? AI will be incorporated, agentic AI. There will be an AI agent, one to do EKG interpretation, chart review, and more important is escalate. If whatever reason person is not answering the phone, the AI agent can escalate to the next level of that. And of course, this is very important in quality assessment and improvement, which was discussed earlier. Patient engagement, everybody knows who Sophia is. Patients actually come and they're looking for Sophia. Where is she? And
I am
as you
Sophia, a
see,
virtual assistant specifically designed to assist patients like you with their cardiac care at Mount Sinai Hospital.
so what we have done using Sophia, that she's making phone calls, pre-procedure phone calls over 4,000 or 20,000 minutes. And if you see what happens, we are using the nurses not for doing the phone calls, we are using them for clinical work. So very important to decrease their burnout as well as use their time towards the clinical patient. So look at where Sophia has gone all around the world. We presented all about her. And finally, what happened is I presented in Dr. Fuster's Cardiovascular Symposium, and it was a most viewed lecture when it came to the talk for 2025, Dr. Fuster's Cardiovascular Symposium. So in 2026, this is what Sophia has done. She was in CRT, ACC. So we are having nurses and nurse practitioners talking about using this conversational AI, go and help see how they can help. And now she's ready. She's boarding to go to Australia, Sydney, for another presentation. That's where Sophia will be going. So we have done so many of this, presentation about Sophia. Now comes, do patients like Sophia? Of course, they want to see who she is. And when they see she's so beautiful, they want to be friendly with her. So the question comes, what is a sentiment when AI agent talks to the patient? We don't know. So if you think here, we did this kind of a sentiment analysis. So you see that most of the patients are neutral or positive. Nobody is negative about it, saying that they do not want to talk about. So this is the future. So just be ready. There'll be no more, mostly no humans. All you'll be doing is dealing with this kind of agent. So what is the future of Sophia? Will be one, epic integration. She'll be doing post-procedure phone calls, and lot of other specialties will be starting using the other areas of the cath lab. And of course, additional language. Right now, she's only speaking English. We'll start with Spanish next.
What is a cardiac
A heart
catheterization process?
catheterization cardiac cath is a minimally invasive diagnostic procedure where a doctor inserts a thin
So that's the future. You see, Sophia will become an avatar, will subsequently start talking to the patient and hopefully consulting patient when they come here. Then comes is procedural guidance. What are we doing with procedural guidance? Once an angiogram is done, AI, quantitative analysis, we are very much interested in understanding bifurcation, automated report, and that will get into CRS. So that can help us getting automatic report. Now coming to my dear subject, which is yellow and personalized medicine. So you will now hear an interventional cardiologist talking on cholesterol metabolism, macrophage, all these things after Philip Swirsky showed us about his understanding. So let's go to it. So yellow one, if you see here, this is about 15 years of work in the cath lab. We took patients with obstructive disease and gave high dose, compared it to low dose statin therapy, and it proved, yes, high dose statin was very important. Then we know statins work. We have to understand the mechanism of how statins work. So we already know one HDL is important, which is efflux, takes it out from the tissue. So I'm only talking about vascular biology, vessel and plaque, where, what you heard earlier was other areas of the body. So we want cholesterol efflux, we know, takes out the cholesterol from the plaque. And how do we understand? Is there something from a person's gene helps us? So that's why we wanted to do gene expression. So again, we took patients, we did imaging, we took blood to understand their gene. And right now we only took one dose, which was a high dose statin therapy. So the genes which changed were genes that were associated with cholesterol metabolism, genes associated with HDL transport, which is ABCA1, ABCAG1, again, shown by Philip Swirsky right now. And more important, we showed the change in plaque, cap thickness was definitely improved when there was a cholesterol efflux improvement. And we did use AI to understand the transcriptomic model. Yellow 3, we added on, because as years go by, there is newer medication. So we wanted to see, do we have to decrease the cholesterol level more than what we think the guidelines are? So we added evolocumab to already maximally tolerated statin therapy in non-obstructive patients. So if you see there in the baseline what it is, then the fibrous cap, and this is the lipid, which is one of the imaging parameters. When they come back, the lipid is completely gone. And how do we know what happens in this patient? At this time, we took bulk RNA sequencing of the PBMC at baseline as a follow-up, but this time was for about 26 weeks. Of course, we saw decrease in inflammation. What we saw first time was the mitochondrial function that improved, change in the lipid plaque. So the question is, can we use this to use a personalized approach? So we'll see that. So after doing this, what we found is there is a group of patients, which is about 80% of the patients, where we call them responders because their cap improved. As you see here, 60 became 90, and the lipid changed. So we called it a melting butter sign. The butter completely melts there, okay? So then there's a group of patients who were non-responders. Means if you see here their chemical, LDL completely changed, 78 to 7. That's what we see in the clinic and tell the patient, hey, you're doing fine. But did their fibrous cap change, or did the yellow, nothing changed them? So we call them as non-responder. So now we have two groups, responders, non-responders. What's the difference? So by imaging and by chemical parameters, we cannot make a difference. Was there any difference in their gene expression? And if you see here, 922 upregulated and about 571 downregulated genes, as you see here. So by using ingenuitive pathway and canonical pathway, there are genes, but important is Are these genes associated with a certain parameter of the pathways? The important pathway that were upregulated, if you see here, most important is mitochondrial function. Okay, mitochondrial function, and mitochondria is responsible for ATP synthesis and oxidative phosphorylation. These are the key things for something to change from probably way of changing their plaque. And a lot of things were downregulated. Most important is their immune regulatory system. Then comes, we had responders and non-responders. Was there a difference in these people, pathways? Of course, responders had good mitochondrial function, non-responders, no change in their mitochondrial function, upregulation in their neutrophil degranulation and inflammatory pathways. Now a patient comes to see us in the office, or a cardiologist. Can we do something, understand their baseline gene? We used a machine learning model. Can we predict based on any of these genetic means, are these going to respond or no? Will their fibrous cap change? So we have identified some of the genes. Same thing, baseline genes. We have identified some gene for change in their LCBI or the yellow plaque. These things are important for the future. Is there a common molecular mechanism pathway between the fibrous cap and change in the LCBI? We did find some common molecular. So one of them was interleukin, not the same thing that Philip Swarsky was talking about, but definitely what we found was change in the macrophage activation. So essentially you want M2, you don't want M1. And more important was this MM9 was associated because this is inflammation. And other thing was CA4 is associated with mitochondrial metabolism. They say it's more of an enzyme responsible for the cell. So what we find is that mitochondria is the key. And that's what we found in yellow 3. Why mitochondria is crucial for changing the macrophage type to M2 and use oxidative phosphorylation. Oxidative phosphorylation gives you the highest ATP, and you need that, not M1. So mitochondria is a center, very important for cholesterol efflux, decreased inflammation, change, apoptosis, and you name anything and everything, it's mitochondria, mitochondria, mitochondria. You need it for cholesterol efflux and macrophage performing phagocytosis and decreased apoptosis. So for everything you need mitochondria. So if you need a change in somebody's plaque, that person's mitochondria has to be good. Question is, how can you improve people's mitochondria? There's no definitive treatment yet, but I think that should be the future. But what things can you do right now is change in improving mitochondria by exercise, because several studies have shown exercise is very important. So this is what we think. You can have a healthy mitochondria by eating right, exercising. Several studies are again showing by doing that you can do that. This is our central figure of the yellow 3 that was published recently this year. So all that I have discussed right now, we created animation. You can see the full animation on yellowtrials.com created by us. So this is what we are promoting. Melt the butter, and you need to have a healthy mitochondria for the future. This is yellowtrials.com. All that I've discussed, all the papers were published. There are several sub-studies that we have that can be done. So future is in yellow 4, from what we studied was that we got to go future of a single cell RNA sequencing and multi-omics approach using transcriptomic, proteomics, and metabolomics. So these are all the various publications from yellow. More to come. We are still publishing, and we are thinking that the future should be AI-driven drug discovery for mitochondria. So we don't have to wait 15, 20 years. We want to do it during our lifetime. So yellow 4 is being done. We'll randomize patient, but what we learned we'll use in yellow 4. We are definitely going to do mitochondrial function. What we did not do is metabolomics and proteomics we need so that we can come with a biomarker, so that when we see a patient in the office, we can come up with a treatment module for that particular person. So we have personalized treatment for coronary artery disease. So this is the final, but more important is Thank you for giving this opportunity. And we have Kinney think tank, which does most of this AI work here in Mount Sinai Fuster Heart. Thank you. Any questions?
Thanks for the fantastic talk, Dr. Kinney. Just opening up to the audience for one or two questions.
Congratulations, first of all, on bridging so many different areas of medicine, AI, genetics, cath lab, really terrific. And I hope that sort of work inspires others here at the Mount Sinai Fuster Heart Hospital across disciplines and collaborate in just the same way. I could ask a lot of questions, but just again, for the sake of time, I'll only ask one. And perhaps it's because your top follow Dr. Swirsky's, but it might be an opportunity to look back again in the data to see if there was increased IN3 expression in the non-responders. So it's something that, if it hasn't already been looked at, might be worth exploring and would be sort of a corroboration of the mouse work and what human studies exist today. Because one is that those people weren't responding. If it turned out that IN3 is the answer, that would bring together the work very nicely. But congratulations.
Thank you.
Fantastic work.
Great point. Of course, we will collaborate. We did have a discussion with the Philippines. Is ready to work with us. Yes.
Any other questions from the audience? All right. Thanks everyone once again.
Thank you.
Okay, next, I would like to welcome Dr. Sikander Hyatt. Dr. Hyatt completed his PhD at the Universität des Saarlanders in Germany before pursuing postdoctoral training within the labs of Chris Sander and Deborah Marks at Harvard University and Memorial Sloan Kettering, where he worked on de novo protein 3D structure prediction. He subsequently joined Bayer Pharmaceuticals, applying machine learning and algorithm development to target identification and biomarker discovery using single-cell data. Dr. Hyatt is also a founder of Sequantrix GmbH, a spin-out from RWTH, focused on advancing AI-driven approaches for drug discovery and validation. In late 2025, he joined the CVRI and the Windreich Department of Artificial Intelligence and Human Health at Mount Sinai, and his lab develops computational and AI-based tools to study immune stromal interactions and cellular dynamics across the cardiovascular kidney metabolic axis, with a particular interest in cross-organ fibrosis. So please join me in welcoming Dr. Hyatt.
Thank you so much for the invitation. I'm really honored to give a talk. Rightly after Dr. Kinney, she had in the last few slides, ideas about single-cell and spatial and agentic AI and using AI for drug discovery, and that's what I will try to bring forward. But I have the wrong slide deck here, so I need to find the right one. Can I just use my computer? All right, let's go with this one, and there will be some surprises. Okay. These are my disclosures, and what my lab is really interested in is collecting a lot of and generating a lot of single cell and spatial transcriptomics data. Using that data, we have been able to create a spatial transcriptomics atlas of the human heart, myocardial infarction. We have created one of the first atlases for human atherosclerosis from coronary arteries, and we have created one of the largest heart failure atlas of single-cell transcriptomics data. What we also then do is not only just generate data and collect all these data sets, but develop really new and advanced artificial intelligence and machine learning tools to integrate all of that data into a common space and then try to find patterns in that, which can then be used for target discovery and disease association, understanding disease association mechanisms. And then finally, what we do is use publicly available data like from the UK Biobank and from open targets to find really kind of causal targets as much as we can in a preclinical way to then use knowledge graphs, AI agents to then come up with target ideas. And I'll show you a few slides on one work that we did with UPenn with Dr. Carl June there, where we used this AI agents to completely autonomously find targets for cancer. And together with Phil, we are developing similar agents for finding targets for myocardial infarction and atherosclerosis. Right. So my mother is really disappointed that I'm not a medical doctor. But what I really want to do is to use data or computer science, that's my background, to find novel targets that can maybe together with the help of clinicians be brought to the clinical stage at some point. And the thing that I'm really interested in at this point is cellular origins of fibrosis. How does fibrosis progress? Where is it beneficial? Where is it harmful? And can we find cross-organ therapeutic interventions for fibrosis? And just to give you some examples of the data sets that we have collected and looked into, one of the early data sets that I started working with was human myocardial infarction. So this is data set collected from roughly 23 patients. This is left ventricle. We have data from the ischemic zone, border zone, remote zone, and fibrotic zone. And on the left-hand side, you see also the time points post myocardial infarction where these data sets these hearts were collected. On these hearts, we did single-cell spatial transcriptomics. These were like early days. So 3 years ago, this was Visium technology, which is 55 micrometer. And we use computational approaches to identify or estimate the cell types that are present there. We then also use single-cell transcriptomics and ATAC-seq data to really kind of cover all different aspects of this data set. Just to give you a kind of a visual aspect of how this data set might look like, I'm showing you 4 rows. These are at the top, the control tissue, border zone tissue, tissue from ischemic zone, and the tissue from the fibrotic zone. We can superimpose different kinds of cells that we observe in there. So you can see at different arrows that, for example, in the fibrotic zone, you have this fibrosis, which is or fibroblasts that are present everywhere as compared to the fibroblasts that we see only in kind of structural areas in the controls. We can superimpose different pathways. So you have TGF-beta, for example, here shown in the control, and kind of TGF-beta in the fibrotic zone, and then we can also superimpose transcription factors. So this kind of gives you a visual kind of idea about what is happening to the tissue. And please don't forget that there is a histopathology tissue that is under it, where we can also extract morphological features that we can then intersect with our single cell or spatial transcriptomics data. But the question here is, these are patterns that we would love to kind of further deeply investigate using machine learning approaches. So there are patterns some patterns are kind of obvious that we can, just an example, show you here. These are the different cell states of cardiomyocytes. So some of them are normal cardiomyocytes, some of them are pre-stress, some of them are more stressed cardiomyocytes. Shown in the top in the single cell world, where you kind of lose the spatial orientation of these cells. You can then superimpose these signatures on the spatial data, and this is data superimposed on a sample taken from the border zone, and you can show this very nice gradient of the normal cardiomyocytes, kind of pre-stress, and the stress cardiomyocytes. But these are easy patterns. But I mean, we need to develop more machine learning-based approaches where we can find these patterns in an automated manner, in an unbiased manner. So this is just an example of a machine learning approach that we use to find the co-localization of these myofibroblasts. So these are activated fibroblasts with SPP1 positive macrophages. So here, these are shown in the arrows here. And we use a very simple approach where we try to predict the expression pattern of one cell type based on the spatial location of the other cell type. So these patterns can then be found, not only just for myocardial infarction or for this data set, but this is a tool that can, then be used for other things as well. And we obviously use it for also other organs and other species. Another example that I have is data from human atherosclerosis. So this is work done together with Novo Nordisk that funded this project as an academic grant. We have data here from 23 coronary arteries from from controls, early stage atherosclerosis and advanced. And what we did here was again Visium 10x, again 55 micrometer, and then we did transcriptomics on it to find patterns in this data set. One thing that I would really address in the kind of work that I do is in all stages of the work, we involve clinicians and biomedical scientists as much as possible. So we did not only just do this annotation and analysis just using computational approaches, but at the same time, we had a human pathologist, I don't know why, like a pathologist, also a human, that was then using, annotated these slides for us, and then we could kind of see where the computational approaches were matching with the pathologist. And what we found here was multiple things. With spatial data, you can find where are these cell types located. So we found this ACR1 positive endothelial cells that were more present towards the outside. We found macrophages that were co-localized with the plaque region. And then what we could also do was look at the cell-cell communication. So we could look at which cells are sending a signal or ligand, for example, and which cells are expressing a receptor, which is then accepting that ligand, and that are also kind of spatially co-localized. So we used an existing tool which uses something called optimal transport, which then superimposes a single cell signature onto the space. So these are shown here with the arrows here. So a long story short, what we found out was that there were these immune cells which have CCL5 as the ligand, and ACR1 positive endothelial cells that were really co-localized in the outside of these arteries. And then we could, together with Jaap Boel in Amsterdam, we could do these diapedesis assays to show that if we have a knockdown of these ACR1 positive endothelial cells, that the adhesion of these T cells was reduced. So the idea that we are now pursuing is that these immune cell recruitment is mediated through these endothelial type 1 cells at the periphery. All right. So more examples of integrative machine learning. So, there's a lot of labs generating single cell data. One of my favorite topics is HFpEF. Just in the last 2 days, 2 single nuke data sets came out on HFpEF, one from Patrick Eleanor's lab and another from another lab, both in US. But all labs are generating single cell data, spatial transcriptomics data. What we thought was that, okay, what are the common and unique mechanisms when we look at all these single nuke data sets from human heart samples from left ventricle that have been generated? So we took this effort and we collected 1.8 million cells from 200 human samples from different disease conditions like dilated cardiomyopathy, hypertrophic cardiomyopathy, myocardial infarction, and ACM. And then we did typical analysis that one would do to find common and unique features. But in addition, what we also did was we went to UK Biobank and we collected all the summary statistics. So basically, we could integrate not only just single cell data, but the genetic predisposition at the cell level, at the single cell level, and then divide the data into patient subtypes. So what you're looking at now are these individual dots, which are not the single cell level analysis, but at the patient level. And we could find different categories of cells, of patients that were falling into different subcategories. We could also find a really unique signature of ischemic cells that were across different cell lineages and was only present in the early myocardial infarction samples. And we could do this validation with new data from Maastricht University. And then we used a large language model. This was a very simple large language model, and I'll show you the multi-agentic model that we built together with UPenn. Using this large language model, what we did was that we fed all the data that we had, kind of integrated from, single cell and spatial and genomics, and all the publicly available data to basically come up with an idea which was kind of pointing to the hypothesis that, well, you have stress cardiomyocytes, maybe they're doing more glycolysis, less oxidative phosphorylation. Is there a molecule that you can find that can then increase this mitochondrial biogenesis and then thus maybe restore the function of cardiomyocytes? So this was a hypothesis that was completely driven by these AI agents. I mean, these things might be very obvious to lots of people in this audience, but for a computer science person where we have thousands of hypotheses now we can generate in an iterative manner and kind of reject and accept these hypotheses. So the way that I'm thinking about it is that instead of you guys looking at the literature and thinking about ideas, we can do quick iteration where AI can assist you in generating hypotheses, and then we can try to, validate or kind of discard this hypothesis in an iterative manner, in a repetitive manner. All right. Just to give you some ideas about this ischemic cell state that we found, if you see here in the green dots, there is this pink kind of stacked bar plot, which is just these ischemic cells that we found only in the early MI samples that we had. We looked deeper into it. First, we thought this is, an artifact from the single nuke transcriptomics data. And but we did then in situ experiments and looked at the markers in new samples. These were samples from early MI, late MI, and DCM and healthy controls. And we could show the markers that we had found, STAB1 and SERPINE1, they were only statistically significantly present in these early MI samples. So we are thinking now of, can these be a biomarker for secondary patient follow-up? So, how do these patients fare in terms of, a secondary hit to their disease? To show you the power of spatial transcriptomics, we then took the same signature and then superimposed that on the MI data that we already had. I'm showing you data on the bottom from control samples. On the top are the samples from ischemic, the sample from ischemic zone. What you can see is in this green highlight, the ischemic fibroblasts are not that present in the control samples. That's what we expect. In the ischemic fibroblasts, you can see some sort of a more kind of bright spots. These are the ischemic fibroblasts. If you compare these just within the ischemic zone, you will see that different regions are highlighting the fibroblasts. The normal fibroblasts are differently located from the ischemic fibroblasts. So this was an orthogonal kind of evidence to show that these ischemic fibroblasts are, have a different identity, and they're doing something else than the normal fibroblasts. We could show this also for the cardiomyocytes, but for the sake of time, just to kind of show you one thing, that these are normal cardiomyocytes and these ischemic cardiomyocytes, again, look at it slightly differently. All right. So, we have all of this data now, and this is like a huge amount of data. You can do a lot of differential expression, cell-cell communication, genetics, and gene regulatory networks. What generally happens in most labs is that you will have a lot of Excel sheets lying around, and you kind of like figure out what is the next thing that you want to validate. And these things cost money, and also resources. So what we thought of was that we will put all of this into a very simple the first AI agent that we made, and then basically try to find out hypothesis and the reason why we should be pursuing that target. So basically what came out of this was these major pathways. So one of these pathways is mitochondrial biogenesis, and then the reasons, like what is the number of citations for this pathway that we want to investigate? Are there other disease associations? What is the association with heart failure studies? Are there any chemical compounds that we can use to target this? And is there genetic evidence? And there can be multiple more kind of like ranking schemes here. So we pursued that. We have the AI agent, we have the kind of the ranking scheme here. We pursued that, and the kind of like the way it turned out to be was that we have data, we did a lot of analysis. We used the large language model. We came up with an hypothesis, which was this PGC1 alpha agonism. And then, I'll show you in the next slide the first experiments we've done to kind of validate this. In the meantime, there are already papers coming out where people have done this in a CRISPR activation screen where targeting exactly the same gene and activating it, gives you recovery of cardiac function post-MI. So what we have done is we've done tunnel experiments where we looked at the cardiomyocyte death. And what you can see on the left-hand side is that if we just have doxorubicin injury, which is like kind of like dropping a bomb into cardiomyocytes, you see a lot of cardiomyocyte death. When you have this molecule that we found, ZLN005, the cardiomyocyte death is reduced. And then when you kind of quantify it in the right-hand side, you can see that this is statistically significantly kind of reduced in terms of cell death. What we are trying to do now is to do this validation in cardioids and in mice. I just wanted to show you one more example of high-resolution spatial transcriptomics data. This is an atherosclerosis collaboration with Corey Levine's lab at WashU. And they had this really cool data set from 27 coronary arteries. And they generated a lot of single-cell Visium and Xenium data. And we were involved in the multimodal integration. And I love this kind of like image. This is coronary artery at subcellular resolution. So you can zoom in, and I can actually tell you where these genes are located, where the cells are, where the nuclei are. And this is kind of like space exploration. It's like, you have a whole universe and you can try to find out patterns here. And that's where AI can be very, very useful because, how many patterns can you find here with the naked eye? Probably, maybe clinicians a lot more, but maybe, others maybe need some AI to kind of look into it. And we have done all of that. So I'm just going to cut a long story short again. We found these fibromyocytes that were co-localized with these lipid metabolism associated macrophages. And then we could show again that this was kind of co-localized on the space. And then Corey's team then developed a biotherapy where they could show a benefit for atherosclerosis in mice. And I think they will pursue it further. All right. Just the last few slides on the multi-agentic CAR-T discovery. Again, this is a surprise, but what I wanted to show you was that this is single cell data. That part is publicly available, open targets, genetics data, those kind of things. We built a reasoning model which can go through all of the data. We use 3 large language models from Gemini, Cloud, and Anthropic, we could find reasons why we should be targeting or why should be selecting a target. This is work done, together with Carl June. So the easiest kind of like way to go forward for us was to test this system in cancers, and we did this work. We have shown that this CAR-T therapy works for colorectal cancer in mice and in melanoma. And this work is in press. This was done by Leon, who's my PhD student, also did work on spatial transcriptomics. And we are now doing similar kinds of studies for myocardial infarction and atherosclerosis. Future directions. We want to build, we heard a lot about AI agents and large language models. We are trying to build, or we are building our own Sinai data generated foundation models. So on the left, what you see is a foundation model which will consume or use all the electronic health records data, like the Biomi data and the Mount Sinai millions data, and we'll try to make a foundation model. A foundation model is basically a machine learning model that is the heart of an AI agent. This is kind of like the brain that is supposed to do all downstream, analysis, or should be able to do downstream analysis on its own. We have some initial results on in silico gene perturbation. So the idea here is we can perturb a gene in silico and give you what it does, or tell you what it does. And we have a much higher, higher accuracy than some of the standard tools that are available outside. And we are also developing our own AI agents, which will do this multi-agentic discussion and then try to come up with target ideas. Of course, all of these things can also be applied in a clinical setting where if we have clinical data available, electronic health records data, that we can design clinical trials and understand clinical trials better. And we are developing our own digital twins. So this is data where we can again use single cell electronic health records, imaging, histopathology, and we can use transformer learning, transformer architectures to basically make our e-patient or like a digital patient avatar, and then we can try to do experiments on those kind of things. So the idea was, I think, as presented earlier in the morning, about trying to do some clinical trial simulations. So a lot of this work is possible because of the environment that I'm in, where people from different backgrounds are coming together. I'm very grateful to Phil to provide this kind of an environment. Alex and Thomas, who are amazing partners already in the last 6 months, we have doing quite a lot of stuff here at Sinai. And my team, Leon, who's doing large language models and AI agents, and Toro, who built the large atlas. You can see there's a lot of collaborations here, and there's a lot of MDs and PhDs working together. So I think for me, that's where the future lies. A computer scientist who can work together with clinicians and biomedical scientists, that'll be, that's fantastic. So thank you very much for your attention.
Thank you, Dr. Hyatt. Do we have any time? We have time for one question. Okay. I can ask a quick question. So we've seen a lot about AI and how it's going to be used clinically. Do you think that there is a lot of growth here at Sinai for the use of AI with considering other talks that we've had?
I think, like Sinai is I'm very new here, but what I've seen in the last 6 months is that there is a huge impetus that has gone, there's a lot of homework that has already been done. There's a lot of data that has been collected. And I think what I feel is that there's this kind of collaborative atmosphere where clinicians and biomedical and AI people are willing to come together. There is a huge potential here. So I'm super excited. I think there's a lot of work that we will be doing together.
Thank you.
All right, we're home stretch here. Just to reorient everyone, we have one more talk from a faculty, and we'll take another 5-10 minutes break, and then we'll sort of take it home with again the future of the future of cardiovascular disease research. We'll take it home with the trainee presentation before we go out and talk to our poster presenters. So Abby is going to introduce our next speaker.
Thank you. It is my pleasure to introduce the last speaker of our faculty today, and that is Dr. Timothy Kenny. Dr. Kenny completed his PhD here at Mount Sinai under the mentorship of Dr. Doris Germain, after which he joined the Bursoy Lab at Rockefeller University as a postdoctoral fellow, where he studied cellular metabolism and nutrient transport in physiology, aging, and disease. In January of this year, Dr. Kenny returned to Mount Sinai as an assistant professor, joining both the CVRI and the Diabetes, Obesity and Metabolism Institute. His research focuses on nutrient transport and cellular metabolism in physiology and disease, with a particular emphasis on choline metabolism. So thank you, Dr. Kenny.
Okay, thank you, Abby, so much for that introduction. I'm going to tell you guys a story today that I hope I can convince you of, that by asking very, very fundamental biological questions, very mechanistic questions, we can understand new physiology and start to understand disease. And so the focus of my laboratory is really on metabolism. And I know we've heard talks today about cholesterol, but when I think about metabolism, I think about carbon and how carbon is moving through a cell, through an organism. And this is a map showing what we know about metabolism. And it looks quite complex, but is actually quite incomplete. There are many metabolic enzymes and transporters whose function we do not understand or know. And on top of that, how these carbons and how these metabolites move in vivo is really something that we have very, very little understanding of. And I would argue that the majority of what we do know about metabolism in vivo has really been focused on central carbon metabolism. So the TCA cycle, Krebs, people are things that I'm sure the clinicians studied in medical school, but there's thousands of metabolites that we know very, very little about. And one of the metabolites that I got very interested in when I started my postdoc was choline. And that's partly from a basic science perspective, it's quite interesting as a metabolite because it's quite pleiotropic. So it has multiple fates once it gets into the cell. For example, it's used to make the neurotransmitter acetylcholine. It's also used to make phosphatidylcholine, which is the most abundant phospholipid in mammalian membranes, across all membranes, organelles, plasma membrane. Phosphatidylcholine itself can be used to make sphingomyelin, which is an important important membrane lipid in the nervous system. And then in tissues such as the kidney, choline can be imported and made into betaine, which acts as an osmolyte, but then betaine itself can actually function through the one carbon cycle to impact epigenetics and transcriptional regulation. So it has a lot of effects from a biochemical and basic biology perspective, but it also, choline metabolism has been implicated in human disease. So it's been implicated most notably in metabolic syndrome, and obviously given the venue, it has been implicated in cardiovascular disease, but it's also been implicated in the nervous system, both the function of the nervous system and neurodegeneration. And there's multiple ways by which you can get choline. So we know that you have to consume it dietarily, but what is the actual fuel of that choline in vivo to fuel these downstream metabolic reactions on the left is really not quite clear. So In one aspect, the kind of classic textbook thinking is that free choline is taken into the cell and used to fuel these downstream reactions. And we do know that you need that only free choline can be utilized in these downstream reactions. But there are a number of metabolites like phosphatidylcholine that are circulating in the blood that could also be taken up, and you can break down and cleave off the choline and use that for your metabolic reactions. And it's really quite unclear what is the predominant source of choline in vivo, that there's whole cottage industries popping up that you need to take this specific choline-containing metabolite in order to boost acetylcholine synthesis in the brain. Obviously, this is pseudoscience, but it just goes to show that there's really not understanding of how choline is flowing in vivo. And so one of the things I did early in my postdoc was try to set out to address this question using empirical models of isotope tracing. And so what we can do with these models is we use metabolites, choline in this scenario, which has a heavy carbon label on them. So the benefit of this, it looks exactly like choline, it is choline, but based on the molecular weight of the carbon atoms, we can detect if that choline came from the choline that we give to the mouse or it's or not. And basically what we can do is through surgical techniques, we can drip in isotope labeled choline into a live, free-moving, awake mouse and ask what happens with the flow of that metabolite in the whole organism context and then down into specific organs. And what we found is that when we infuse choline into the mice, we rapidly reach a steady state of labeling. So about 20% of the total choline pool circulating in the serum of these mice is coming from the heavy choline that we're dripping into the mouse through this jugular vein catheter. And these kinds of analyses allow you for the first time to make assessments on what the relative flux rate or how quickly a whole organism is taking up a given metabolite. And we know that it's metabolically active because we can look in the serum and see downstream metabolic fates of choline, like betaine and phosphocholine, and see that those are coming from the isotope labeled choline that we're infusing into these mice. And as I was mentioning a second ago, we can make calculations based on what is the total usage of this metabolite by a given organism. And this, we can calculate the circulatory flux of this metabolite of choline, and this puts it on par with the usage of many of the essential amino acids, for example. And if we go and we look into different tissues, we can see what percentage of free choline is being taken up by different tissues and how quickly are they turning over the total amount of choline in those given tissues. And you can see the details here are not super important, other than I guess the heart is the most abundant tissue that takes up choline in terms of how quickly it does. But this is just going to show that choline itself, free choline, is a predominant source of choline in mammalian cells in vivo, in organismal physiology. And we can go and look at the downstream metabolic fates of choline. And what we can see here is that free choline is really fueling the downstream synthesis of all these choline-derived metabolites. And that led us to ask the question, how is choline being taken up from systemic circulation? And we do know that choline must be obtained from the diet. And we know that given its positive charge at physiological pH, it needs to be transported into the cell. And we know the concentration of choline in the blood, for example, is about 10 micromolar. And the only transporter that had been reported in the literature to function at physiological pH was this choline transporter that's in cholinergic neurons. And this transporter works at the cholinergic synapse to reuptake choline after acetylcholine is released in the synaptic cleft and hydrolyzed to make acetate and choline. And it was kind of thought that the collective action of these four transporters were what fueled choline transport for all other cell types. And the thing that never made sense to us when we first started thinking about this is that the affinity of these transporters is way lower than the physiological concentration of choline, which led us to hypothesize that maybe a high affinity, ubiquitously expressed choline transporter was yet to be described. And so we set out to try to find this, and we turned towards human metabolite GWAS data sets. And these were coming out right around the time that we were thinking about this, and these are just GWAS data sets in which serum metabolite levels are also measured. And for the sake of these studies, they were using them to do associations of clinical phenotypes with circulating serum metabolite levels or clinical phenotypes with variants in the genome. But we asked, could we use this as a discovery platform? So could we find variants in candidate genes and genetically associate that with differences in circulating serum metabolite levels to kind of discover new genetic causalities between candidate genes and what they might be transporting. And this works. So for example, variants in LDLR are associated with different levels of cholesterol in circulation. And so with the confidence that this system seemed to work, we turned our attention to choline. And we were excited to see that this transporter called FLVCR1, which is ubiquitously expressed across all mammalian cell types, and had been annotated previously as a heme export protein, that it was associated not only with phosphatidylcholine, the most abundant phospholipid in mammalian cells, but also the upstream metabolite of that, leaving us to hypothesize maybe this is functioning as a choline transporter. So to test this, we used CRISPR to knock out and cDNA supplement cell lines. And when we performed steady-state metabolomic profiling, you can see that choline and these choline-derived metabolites were down in the knockout cells compared to add-backs. We could also put radioactive choline on these cells, and we showed that FLVCR1 was actually required for the uptake of radioactive choline. And we were able to resolve a cryo-EM structure of FLVCR1 bound to choline, identifying the structural mechanism by which this transport happens. Now, those pretty clearly show that FLVCR1 works as a choline transporter in vitro, but what about in organisms? So we found that FLVCR1 knockout embryos were embryonic lethal and died at E12.5. So a day before this, at E11.5, we did metabolomics and we found exactly what we saw in cell lines. So we see a decrease in choline and choline-derived metabolites in these knockout embryos. And if we give pregnant moms supraphysiological amounts of choline, we can extend the developmental lifespan of these embryos, suggesting that this is what is in fact limiting during development. And this is interesting from a clinical perspective because there are patients with rare missense variants in FLVCR1, and it's associated with this syndrome called PCARP, which these patients present with very severe ataxia that develops in early childhood, and they eventually go blind from retinitis pigmentosa. So this led us to ask, could we make a mouse model to kind of understand the pathophysiology of PCARP disease? And so we used a tamoxifen-inducible ROSA26 Cree model, which knocks out FLVCR1 in all tissues when we give the mice tamoxifen. And what we found is that when we do this, these mice get ataxia. So one of the kind of, for people in the audience who have held a mouse before, usually when you hold a mouse, it keeps its legs out to the side. But when you hold a mouse and it keeps its legs to its core body, that's usually a telltale sign of ataxia in mice. And we can score this phenotype and ask them to, for example, walk across the ledge of a cage. They do very poorly at that. The kind of gold standard of an ataxic phenotype is a rotarod test, and these mice, as expected, do very poorly on a rotarod. So when we knock out FLVCR1 in all tissues, they phenocopy what we see in patients that they have this ataxia. So we next asked which tissue is responsible for this, and naturally we suspected that maybe neurons would play a role. So we used an AV strategy to knock out FLVCR1 in neurons of the central nervous system only and ask, is loss of choline transport in neurons of the central nervous system sufficient to cause ataxia? And that's exactly what we see. So you can see here, the mouse on the right is lacking FLVCR1. It has this very characteristic clasping phenotype, where the mouse on the left is normal. And you can see if we ask them to walk on a ledge, they can't do this. And obviously we can quantify this. It's quite a robust phenotype. And we're still kind of chasing down the mechanism of what exactly is going on here. But one of the interesting things that we found is that when we profile different parts of the nervous system in these mice, we see rampant neural inflammation. And this is just showing a staining of GFAP. So you can see there's some gliosis that's pretty severe in the knockout mice compared to the controls. And one thing we did really want to get down, nail down on is choline deficiency truly limiting for this phenotype? And to do this, we took advantage of a classic genetic approach where we introduced a gene that we know does something else and asked if it could supplement the thing that we think our gene of interest does. So for example, we went back to that presynaptic choline transporter that I told you about in cholinergic neurons, and we expressed that in the same viruses where we knocked out FLVCR1. So we asked, could you, by expressing this cholinergic choline transporter, could that rescue the defects that we see in the FLVCR1 knockout mice that don't have choline transport in their neurons? And that's exactly what we see. We see a complete reversal of this phenotype, and it's quantified here, and you can see. So this at least tells us that the deficiency of choline in neurons in FLVCR1 knockout mice is causative of this phenotype. And we're still chasing down kind of the mechanism and what exactly which neurons is happening, which metabolite is limiting. But I would propose that what we're trying to do in my lab is really use this mouse model as a tool to understand what are the different tissue-specific functions of choline metabolism. And exactly, what are the other tissues? What else happens when you knock out choline metabolism? And you might say, you already did the whole body knockout mouse and you told me it has ataxia. What else are you going to find? Well, one thing I didn't mention is that if you knock out in the whole body knockout mouse FLVCR1, these mice become morbidly obese on a standard chow diet. So they get up to 60 grams. So that suggests there's something very fundamentally going on with choline metabolism and diet and body weight. And as you might expect, these mice are obese because they have much more fat. And so that's something that my lab is actively chasing down now. And one thing I will highlight here is this StarNet study from Sinai, actually, that has associations of genes that are associated with different cardiovascular disease-modifying clinical parameters. One of the 11 genes that is associated with high LDL and high HDL is this transporter FLVCR1. So I would argue that by asking very fundamental questions like how does a metabolite get into a cell, we can work that all the way up into animals and find new biology about organismal biology that might inform our understanding of disease. And with that, I'll thank my lab, especially the members who've taken a chance on a new faculty member, and my postdoc mentor and funding. And I'll gladly take any questions.
Any questions, Dr.
Thank you, Tim. Always fantastic talk, super interesting. Have you looked also in models of neurodegeneration, Alzheimer's, where we have the proper deficiency and still choline as a cornerstone of the disease? And do you think that your transporter is an agent of that?
Yeah, that's something we're definitely looking at. So do we have direct evidence? We don't have direct evidence that FLVCR1 is implicated in neurodegeneration or Alzheimer's. One thing I will say, it is also known that phosphatidylcholine metabolism is perturbed in Alzheimer's, so maybe that's playing a role. But we're making, tissue-specific and neuron-specific knockout mice, crossing them with Alzheimer's mice and trying to tease some of that out. But I do think it could be a generalizable mechanism of dysfunction in the nervous system and how that interplays with Alzheimer's or other neurodegenerative diseases, something we want to look at.
It's a very fascinating. I really enjoyed it. I seem to recall that in the beginning when you had your heavy carbon isotope experiment, there seemed to be a lot more uptake in male compared to female animals. I was wondering whether you could speak to that and maybe also expand it to your receptors and comment on whether there's differential expression across different organs.
Yes, it's a very good point. I didn't mention that. It's good you picked it up. So there are, what Nicole is talking about is that in the circulating serum choline levels, when you calculate flux, there's a very clear separation between male and female mice, suggesting that there's differences in the systemic demand of choline between male and female mice. And I think that might actually be happening because I said that choline, you have to get it from the diet, and that is true. You mostly have to get it from the diet. But there is this pathway called the PEMT pathway that's mostly active in the liver that seems to be under hormonal control. And so that takes phosphatidylethanolamine and makes phosphatidylcholine. And you could imagine a scenario where that pathway is, under the control of the estrogen receptor and maybe more active in female mice than male mice, so they don't have as much demand for de novo choline coming into them. So that's what I would guess on that, but we haven't touched that at all, but it's very interesting.
Any more questions? Thank you very much, Dr. Kenny. Apologies, one more.
I won't slow some questions, but I just want to say this was an outstanding presentation. That was Dr. Ives, and really wanted to congratulate Dr. Swirsky on two outstanding recruits, really phenomenal additions to Mount Sinai Fuster Harding, as well. Thank Dr. Fuster for generating the philanthropy that allowed those recruitments, but really wonderful team effort. Congratulations.
Thank you.
All right. Let's stretch our legs for the next 5 minutes. Dr. Fuster said 2 minutes. But most importantly, I want, if you've not had a chance to scan the QR code, please do. Helps us track attendance and sort of, gives us or give the administration a reason to continue this forum every year, so we can get a good sense of attendance. So Dr. Fuster said 2 minutes. Let's stretch our legs, use the restroom, and we'll come back for the final lap to support our trainees.
We're going to go ahead and get restarted here in a moment. If people can gather once more.
Yes. That's good. Okay. So, this competition. I think Dr. Swirsky and I'll get up and these out.
I think this one, I don't know how you want to do, but it's for the posters. I think they'll be getting. You can just find it.
Do you think it's screaming now?
I think so. I think so.
So then.
If you can make the final, yeah, if you can.
You make the decision and get it clear.
Oh, we'll keep it together outside.
Oh, those are the benches somebody else.
Yeah, I think we're gonna should be outside. Then it's still gonna get people still in there. So just to keep it now, many of them are bringing their phones. Then you go. Hopefully, yeah.
I would trust.
All right. Welcome back, everyone. Again, if you haven't had a chance to sign in, please do. We have the QR codes everywhere outside. Okay. All right. So it's my pleasure to introduce our next trainee oral presenter. Dr. Juan Antonio Requina Ibanez. He is a postdoctoral research fellow at the Mount Sinai Fuster Heart Hospital, training cardiology and advanced cardiovascular imaging in Spain. It's been like imaging theme today. His work focuses on HFpEF, cardiometabolic disease, epicardial adipose tissue, and the mechanistic effect of SGLT2 inhibitor. He's also received currently two postdoctoral fellowship awards from the American Diabetes Association in 2024. And most recently this year, he also received an award for a research award from the American Heart Association. So it's with, please join me in welcoming Dr. Requina Ibanez, who is going to be presenting sotagliflozin improves symptoms and functional capacity in non-diabetic patient with HFpEF, result from the SOTA-P cardiac trial.
Thank you for the introduction. I'm going to present the result of the SOTA-PCARDIA, which is a clinical trial evaluating the effect of sotagliflozin in HFpEF patients without diabetes. As we know, heart failure is a major global health problem with associated incidence of obesity, cardiometabolic disease, diabetes, and hypertension. More in particular, HFpEF account for more than half of the cases of all cases in heart failure, but most importantly, HFpEF have limited effective evidence-based therapies. There are two groups of drugs, SGLT2 inhibitors and GLP-1 receptor agonists, that have demonstrated different benefit in HFpEF. However, big clinical trial with SGLT2 inhibitors seems to show an attenuation of benefit at the highest range of ejection fraction. Most recently, two big clinical trials, the SOLOIST and the SCORE, evaluated the effect of the dual SGLT2 and 1 inhibitor sotagliflozin and reported similar benefit regarding heart failure events. In contrast with selective SGLT2 inhibitors, sotagliflozin may potentially engage additional molecular function associated with the transporter SGLT1. SGLT1 is a transporter which is widely expressed in the human body, particularly in the intestine, and the inhibition of SGLT1 in the intestine is associated with endogenous release of GLP-1. However, in any case, these two clinical trials just included patients with diabetes, and just the SOLOIST included patients with HFpEF, a small percentage, around 20%. Therefore, the effect of sotagliflozin in non-diabetic population and the effect also in HFpEF is still unclear. That's why we designed the SOTA-PCARDIA, which is a randomized, single-site, controlled placebo trial evaluating the effect of SOTA in a truly HFpEF population. Every patient has a baseline MRI, thus ensuring an ejection fraction of at least 50%, and 88 patients were randomized to receive sotagliflozin or placebo over 6 months. We evaluated cardiac structure and function with cardiac MRI, laboratory testing, diastolic function with echo, functional capacity with CPET and 6-minute walking test, and quality of life with the Kansas questionnaire. These are the major results from the SOTA-PCARDIA. The primary endpoint in this clinical trial was LV mass, and we observed a significant improvement in cardiac remodeling as sotagliflozin led to a significant reduction in LV mass compared with placebo and after 6 months. Sotagliflozin also induced a significant reduction in left atrial volume in this patient. We also observed an improvement in diastolic function measured with echo with E2E prime and in NT-proBNP, thus suggesting improvement in congestion. Those changes in congestion, in cardiac remodeling, and diastolic function, most importantly, were associated with changes in functional capacity and quality of life. Those patients treated with sotagliflozin experienced a significant improvement in 6-minute walking test and also in the quality of life measured with the Kansas. We did the response category analysis, and while almost 50% of the patients in the placebo group did not report any changes, a greater proportion of sotagliflozin treated patients achieved at least 5% in the Kansas, which is the cutoff, is the minimum clinically referenced difference. These changes also parallel the changes in NIHA functional class as per inclusion criteria. All patients were at baseline class functional 2 or 3, but after 6 months, a significant greater percentage of patients switched to class functional 1 in the sotagliflozin group. And in conclusion, in this trial, sotagliflozin improved cardiac remodeling measured with echo and with MRI. improved functional and patient-reported outcome, but most importantly, this benefit extended the effect of the drug to a truly HFpEF population, and also to patients without diabetes. We also included a very diverse population, as 89% were non-white, 66 Hispanic Latino, and more than 70 were female. That's supporting a extended role of this drug in heart failure. That's it. Thank you for your attention.
Very nice presentation. I have a question for you, but honestly, it's not my question. Heart failure expert, an international heart failure expert, recently asked me this question about that data. Just realizing it, I'm from Mount Sinai. The effects of SGLT1/2 here, which were described in Solson's 4-hour SGLT2 inhibitors in different pivotal trials. Many of the Kansas City cardiomyopathy questionnaire. And have not seen that large a difference. In fact, in the Solus trial, which I've shared, we found a difference in statistically significant, about 4 or 5 or so on that scale. Same with the EMPA and DAPA trials. Those trials all showed some increase in placebo. It's often because you have some with heart failure, there's a Warden effect, a Hopper effect, a placebo effect. So it tends to go a bit more than the very small amount going to appear. And likewise, it tends not to go up that much in drug. And then you do the delta. This is the correct comparison. It is baseline versus final follow-up, drug versus placebo. It usually is in the range of 4 or 5 for this class of medicines. There are other medicines, Camden, which the cardiomyopathy you might get involved with, changes in KCCQ. Device-based therapies, unblinded therapies, sometimes you see more. So his question to me was, how is it so much larger than seen with the other compounds, or even this compound, larger than most people train?
That's a really good question. First of all, I would say patient-reported outcomes and quality of life are subjective, so we cannot rule out the own patient interpretation of the improvement of benefit might have been taking a role here. Also, it's a small clinical trial, as every MRI clinical trial. But most importantly, I could say the improvement we saw in quality of life and also in functional capacity are associated and correlated with the improvement we saw in MRI and ECMO, especially the reduction in LV mass, reduction in body weight, and adipose tissue, which is something we are also studying now.
Next, I'd like to introduce Stephanie Song. Stephanie Song is a 5th-year MD PhD candidate in the lab of Dr. Nicole Dubois in the Department of Stem Cell Biology and Regenerative Medicine. She's studying embryonic heart development with a focus on the role of the RNA binding protein DDX3X in the developing endocardium and how it may contribute to congenital heart defects. So let's introduce Stephanie.
All right, thank you for the introduction, and I'd just like to thank the organizers for this opportunity. So I study the gene DDX3X. This is actually an RNA binding protein that acts as an RNA helicase, and it's known to have a variety of functions in the cell throughout the life cycle of an RNA transcript, some of which are shown here. And most of what we know about DDX3X comes from the neurodevelopmental literature because mutations in DDX3X cause DDX3X syndrome, which is primarily characterized by a variety of neurodevelopmental disorders. But recently, clinicians have also found that these patients are at increased risk of congenital heart defects. So kind of continuing with this theme of the brain and the heart, we believe that DDX3X is playing a role in cardiac development. I know many of the speakers before have been talking about cardiac events that happen closer to the later in life, and I would really just encourage you for the next couple minutes to think about how did this all start and what is the role during embryonic development. So another thing about DDX3X is that it's known to play very cell type specific functions. So my specific question is, what is the role of DDX3X in the endocardium during cardiac development? The endocardium is the inner lining of the heart, and we know that it plays a critical role in many of these functions during development and can contribute to congenital heart defects. So before getting into the results, I want to introduce the genetics a little. DDX3X is actually an X-linked gene. So females would have 2 copies of the gene. However, there is a homolog on the Y chromosome called DDX3Y, and it can partially compensate for DDX3X in some tissue types. So using a mouse model that specifically deletes DDX3X in the endocardium, I've been able to generate this allelic series of 5 different genotypes that I won't get too much into the details, but it represents a gradient of total DDX3X plus Y levels. And my prediction is that the phenotypic severity will reflect the total levels. So when we do this endocardio-specific deletion, we find that the female double mutants are actually embryonic lethal at E13.5. Here we see that the heart is smaller and does not contain any blood. And when we take a closer look at the ventricles, we see that the endocardial lining, which is marked in green here, is compromised. And so we wondered what is actually happening to these cells. Perhaps the endocardial cells are dying, or perhaps they're not proliferating enough. So first looking at apoptosis, we used the cleave caspase 3 marker and did indeed find that an increased number of endocardial cells in the female double mutant are undergoing apoptosis. And when we used Ki67 as a marker of proliferation, we actually found that a higher proportion of endocardial cells were Ki67 positive. And so this was the opposite of what I'd predicted given the phenotype that we see. However, actually similar findings were found in neuroprogenitors. And so a previous study actually found that when you reduce DDX3X, the cells tend to be stuck in the cell cycle, accumulate Ki67 without actually proliferating more. So we think that a similar mechanism may be happening in the endocardium in our animals. So to really dive deeper into this mechanism, we performed ECLIP, which is a way to identify the actual RNA transcript that are bound by DDX3X, as well as the binding regions. We found that in line with previous studies in other cell types, DDX3X does bind to a variety of transcript regions. And one of the significant Go terms that came up was the positive regulation of mitotic cell cycle. So again, that reiterates our hypothesis that DDX3X is playing a role in cell cycle. So I've told you about the female double mutants, but what happens to the males? The male mutants actually survive until adulthood. By 6 months of age, we see that they have an enlarged heart. And by 9 months of age, we see this really profound systolic dysfunction in these animals. So in summary, we think our working hypothesis is that DDX3X is really helping to endocardial cells to progress through the cell cycle in order to meet the proliferative demands of the embryonic heart. And when we have a deletion of this gene, the cells are not able to proliferate adequately, they die, and that leads to embryonic lethality. We think that the male phenotype is representative of an intermediate dosage. And some of the remaining questions that we're really interested in are, how exactly is cell cycle being regulated by DDX3X? We also know that in the embryonic development, there's a lot of crosstalk between the endocardium and the myocardium. So we're really interested in understanding whether there are any changes in the myocardium in these animals, any changes in signaling. And we're really excited to be exploring this by, I think my slides are not advancing, but I'll just say it. So we're excited to explore this by using spatial transcriptomics. So we've collected embryonic hearts from all 5 of the genotypes at 3 different time points. Yeah, some of the animations are not popping up. It was just the last slide. Yeah. I think it's just a really large file. It was just on the last slide of my acknowledgements. It's okay if. That's okay. Thanks for bearing with the AV issues. So essentially, we were performing spatial transcriptomics on a time series of embryonic hearts, and we're really excited to use those data to answer our remaining questions. So I'm not sure if the acknowledgement slide will pop up, but I do want to just acknowledge and thank everyone who's involved in the project, everyone in the Dubois lab, our collaborators, there's a DDX3X community at Mount Sinai that have been really instrumental in kind of bridging the clinical aspect with this work. Of course, the organizers for this opportunity, and I'm happy to take questions. We'll see if the slides pop up eventually, but if not, happy to take any questions.
Thank you so much. Are there any questions for Stephanie?
Wonderful talk. You mentioned this arrest or coming back of the cell cycle in your lifetime, but what about adulthood? What is the pathophysiology there of this very marked contractility effect that you see in these mice?
Yeah, that's a really great question, and it's definitely something we're still exploring. So I will say that the endocardium is highly proliferative during the embryonic stage. We're not sure if it's quite as proliferative in adulthood, and so it's possible that it's impacting cell cycle there. But we think what may really be happening more likely is that early on during embryonic development in the males, there may be a very mild change in the endocardium and cell signaling that impacts the formation of the myocardium. But because the heart it's such a vital organ, it's really able to compensate in terms of the function until perhaps adulthood, when the small changes are maybe just not really able to keep up with the function of the heart that late. So that's also why in the transcriptomics data, we're looking at the male knockouts in the embryos to see if there are already changes as early as embryonically that maybe just don't even manifest until later in life.
Any further questions? Thanks, Stephanie.
And for our last speakers of the day, I'd like to introduce Kennedy Salamat. Kennedy is a third-year MD PhD student mentored by Dr. David Sachs and Dr. Kevin Costa. She's pursuing a PhD in AI and emerging technologies, where her work combines cardiovascular organoid research with cutting-edge approaches in machine learning and bioengineering. So let's welcome Kennedy Salamat.
Hi, everyone. Thank you to the committee for the opportunity to speak today. So I'm going to be talking about cardiac microorgans. So as you all know, cardiovascular disease remains the leading cause of death worldwide, making it important to study disease mechanisms and also develop tools for high-throughput drug screenings. However, current model systems require improvement. So one striking statistic is that 90% of clinical trials for investigational drugs fail, in large part due to toxicity is not detected in preclinical studies, with cardiotoxicity being a common culprit, thus highlighting the urgent need for human-specific models to complement research in other model systems. Cardiac organoid models hold significant promise, but they also have limitations, namely disorganized morphologies. On the right-hand side of the screen, you can see a cardiac organoid. This is what most cardiac organoids in the field look like. So you can see there's no clear atria or ventricles or clear structures. There's also a lack of flow, making it difficult to model certain diseases, and heterogeneity, making reproducibility challenging. So to try to encourage more biomimetic growth of microorgans, our lab built a custom microfluidic cardiovascular chip, the microCV chip. You can see that on the left-hand side. And each chip holds 8 cardiac microorgans, which are connected. So each well is connected to an arterial and venous port, and then those are connected by a shunt to allow for the development of circulatory flow. And we've also built a custom robot for our incubator. You can see that on the right-hand side with 3-channel fluorescence and bright field imaging capabilities, and it can monitor up to 12 micro CV chips at a time for a total of 96 microorgans. So in the micro CV chip, we occasionally get structures that look like this. So you can see it's a lot more organized when we contrast with what we saw before on the first slide. And these microorgans contract laterally to move fluid axially through the tubular structure. So this is very exciting to us, but again, a big problem in organoid biology is reproducibility. So these structures are very rare. So then we ask the question, can dynamic protocols that incorporate feedback produce consistent microorgan structures? So what we propose is to continuously monitor microorgans as they develop, predict their developmental progression, and then when the predicted progression diverges from what we would like to see, we can do real-time interventions. So in the lab, we have several interventions that we can use that we've developed. So we're able to trim cells into the pattern that we want by using photoactivatable phototrexate. We can also push cells into different patterns by photo-initiating hydrogels, and we can also create growth factor gradients in our chip. So again, we would do real-time interventions when we saw things were diverging, and then this cycle would continue of monitoring organoids, seeing when the development is going off track and course correcting to hopefully consistently produce these more biomimetic tubular structures. So the first step of this project is to set up continuous monitoring of microorgans. It's important to be able to continuously monitor them, and that way we can know how they're developing and then intervene. This is actually a really challenging problem, time-lapse imaging and autofocus for organoids, because custom image processing workflows are not robust to artifacts or changes in lighting. So to try to address this and create a robust time-lapse system for a microscope, we use model-based reinforcement learning. And so what model-based reinforcement learning is you train an agent to complete a task by giving it a reward function. So for example, you would give it a big reward for finding the goal, and you might give it a small penalty for each step taken if you were trying to get it to find the goal in the most efficient way with the least number of steps. So we use model-based reinforcement learning. On the left-hand side, you can see again a chip with 8 cardiac microorgans, and the goal is to start somewhere and then be able to reliably find all 8 microorgans and not get stuck on any artifacts. And to make sure that our time-lapse and autofocus system is robust to any artifacts, we actually do a lot of data augmentation where we generate a lot of simulated chips with a bunch of artifacts so that time-lapse is prepared for anything that it could possibly see. So on the right-hand side, I have a video of our simulator from the microscope's field of view. So this is all a simulation that we created. This isn't a real chip, but we can create lots of these simulated chips for data augmentation. So this is the well, and then you can also focus up and down in the simulation as if it was actually a microscope. So for future directions, we're assessing the performance of the reinforcement learning agent and benchmarking against other well-established algorithms. We're also completing many cardiac microorgan differentiations for more data to improve the developmental trajectory predictions. And then in the process of utilizing AI to suggest interventions to course correct development so that we can hopefully consistently, again, get these more biomimetic tubular structures. So with that, I would like to thank the Sachs and Costa Labs, our collaborators, my thesis committee, and our funding sources. And thank you all for listening.
Thank you so much. Any questions? Thank you, Kennedy. If I understand correctly, your output or your readout is mostly imaging-based?
Yes.
Can you comment a little bit on whether you can expand that to maybe functionally relevant metrics within sort of your incubator system, where you could, monitor cardiac function or like any kind of functional parameters?
Yeah, so we're able to electrically pace organoids too to get that sort of data. And then we can also administer drugs. So that's one test we've done in the past. We gave isoproterenol and verapamil, and we saw that they responded as expected in terms of beat rate and contraction profile. And then also another future direction is to be able to, so there are in silico methods where from bright field imaging, you can actually also predict what certain markers will look like as if you had stained for it. So that's also something we're developing to get real-time feedback as well.
Any more questions?
Okay, really great presentation, Dr. Harrington. He was just commenting that they'll likely need more funding, he said, from NIH for this type of work is, perhaps to some extent it replaces animal-based research. It's interesting. I was actually reflecting just in the past week. One of your faculty, Dr. Edino, his name was mentioned earlier. He's a collaborator with Angelos. He was named editor-in-chief of the European Journal of Cardiac Surgery. And Kimberly put out his first editorial, and he has a lot of plans. One of them, though, is that they won't accept animal research. So that is an interesting development, I think, in the field. Do you think that in the future this will indeed happen? Say, not in the next 1 year, 3 years, or 5 years, I mean, 20 years, obviously.
I think there's definitely, like you said, some improvements that need to be made. So also there's a lot of research for incorporating other cell types. So like immune cells aren't that commonly used in cardiac organoid models. So that's another hurdle that we'd have to overcome. But I do think that at least to complement animal research, this is going to be a very important direction.
Thank you.
All right. Well, it has been a fantastic day for sure. I hope everyone enjoyed it, but the best is yet to come in many respects. So even though we're wrapping up what is happening together in this room, now is time to move out for the posters and a poster competition. So at the end of that, we will hand out some awards, 3 different awards for one for the best oral presentation. You saw 6, and we're going to confer here in a bit and decide on who that is. Also, the best fundamental science poster, the best clinical science poster, and what was down here? Oh, yeah, the best clinical case poster. So, and there's one more too. I think that's the innovation one, if I remember right. Yes, the best innovation, digital health, and technology poster. So, lots of great things hanging out there. I've checked out a number of them myself, but I'm going to rapidly take Dr. Harrington and Dr. Swirsky, and we'll go around and take a look and then announce the award winners. But regardless of who wins these different framed awards here, as I said, I did get a good look at a number of the posters and really outstanding work that you're all doing. You should all be very proud. Thank you for coming today. I think it's been a really collaborative and instructive day, educational for me. Dr. Swirsky, any comments you want to make? Oh, all right, then thank you all. Hope you enjoyed the day and see you next year.
We're about to walk around now.
Yeah.
I'm guessing you don't need this anymore.
No, I don't need it.
Just please take pictures, maybe. Would definitely go with your suggestion. But I agree, I think that it's not in the body. Terrific, thank you. I'm just putting it in the order. When each person comes up, Dr. Schwartz, I'll take a picture and you've been filming it as well. And then once we do the 5 awards, 1, 2, 3, 4 plus space, then we're done, right? Could you just tell me? Yes, well, finger on this one. Okay, so we do the boosters.
It's time to give some awards. So thank you all for staying to the very end. So what we will do first is give away awards for posters, which were thoroughly reviewed and judged. And so we have winners. So I'll just announce the name. And so please come up to receive your award here. So for the fundamentals/translational science, the author, the winner is Jia Song. So this is posted D31. Jia? Is Jia here? So what do we do? Do we give it to somebody else now?
So it's actually one of the rules, but we'll be nice.
All right. The poster was L39X cardiomyopathy is distinct from PLN knockout evidence from isogenic human iPSC and knockout models. Congratulations to Gia wherever you are.
Yeah, those were the rules we used last year. You had to be here to win, but we'll be nice about it, I guess. Okay, up next is clinical science, and the winner is for D21, leaflet-specific aortic valve calcification and permanent pacemaker implantation after TAVR in classical and paradoxical low-flow, low-grade aortic stenosis, Dr. Pragati Basera. The senior author is Dr. Larakis. Congratulations. Actually, we'll come over. I'll be sure we'll give them the end. Yes, share the credit. You're part of the team. Anybody else? All right. And that we will put here. Okay, next up is the best clinical case poster. This is for clinical cases. And the winner there is D12, successful, I feel like I'm playing bingo. D12, successful treatment of left ventricular outflow obstruction with transcatheter edge-to-edge repair of the mitral valve. Author, Dr. Leila Alizadeh. And the senior author is once again Dr. Larakis. You're working overtime, aren't you? That's pretty good. All right. Congratulations.
Thank you.
And, oh, come on. Yeah, so.
Thank you so much.
Yes, congratulations again. Okay, and the last poster that's in the Innovation, Digital Health and Technology and Implementation Science category. This one goes to D11, Marjalian Jaha, an educational hemodynamic AID, an educational application for interventional hemodynamic monitoring and functional testing. Oh yeah, come on. You should be in here. Good to see you. How are you? Great job. Wonderful. All right. So we are in the home stretch. Thank you again, all of you, for staying. And next up is the best oral presentation. But before that, I do have to thank once again our Research Forum Planning Committee, which Dr. Akin Molayami chaired. A round of applause for his great work. And the rest of the members, Doctors Abby Glick, Anna Radhakrishnan, Mike Vavronakis, and Abby Yates. Where are you all? Stand up so that people can see you. There, at the very end. Oh, okay, but stand up. People should see who you are. Oh, you have food on your lap. Then you don't have to stand up. Enjoy your food and drink instead. Great. And there were a bunch of peer reviewers. Actually, they were the ones in the committee that selected all these folks, just so you're aware. It actually wasn't either of us that were involved with that selection, although we agree with it. Those look like good posters. But the peer reviewers were Franz Birken, Solomon Beanstalk, Matthew Cagliostro, Anton Kamaj, who was a former fellow who was orchestrating this event, Harry Choi, Jeffrey Downey, Madison Edens, Leigh Gadecki, Amit Huda, Timothy Kenny, Amy Kontorovich, Joshua Lampert, Cameron McAlpine, Tanner Monroe, Noah Moss, Neev Granat, Jeffrey Olin, Shreyans Patel, David Power, Lucy Safi, Matt Tomey, and William Wang. So those were the peer reviewers that reviewed well over 100, I don't know the exact number, but a lot of abstracts. So a round of applause for them as well. And the final winner here for the best oral presentation, and this was actually done by the judges, that is Dr. Fuster, Dr. Swirsky, myself, and Dr. Harrington were the ones that were judging here. We thought all of them were excellent. It was really a very difficult decision. I would say all of those presentations truly were winners, but now the one when we counted up the votes just now, Dr. Swirsky and I, that rose to the top was Dr. Stephanie Song. So congratulations, Dr. Song. And her senior mentor is Dr. Nicole Dubois, so congratulations to her as well. she might have left already, but congratulations to her as well. And I do want to say you didn't win because of sympathy points for the AV problems, though Dr. Harrington was particularly impressed with the calm demeanor that you maintained while that happened. That's not easy to do, but it wasn't for that. It was actually for the quality of your presentation and the work. So congratulations. So I think that's everyone. Just we have to remember not to misplace that one. But it's just in closing, it's Friday, it's late, but anyone that wants to stay and take a look at the posters, if they didn't get a chance or help themselves to any hors d'oeuvres or take something for the road, go ahead and do that. But otherwise, we're done. Thank you so much for attending, your active participation, the people that contributed the posters and the oral presentations today, as well as those of you in attendance. Thank you so much, Dr. Schwartzberg.
So just thank you for coming and see you again next year. Well, before then, but at this event next year.